Okay, Piyush, are we live?
I'll let you know, man.
Yes, we are.
You can start, man.
तू शेअर करतोयस संदीप?
हो करतोय सर.
मी करतो.
केलं मी सर.
ठीक आहे.
Sir, Kadam sir, you can just answer for a minute.
Yeah, sorry.
Yes, Manisha, you can start.
Yeah. Okay, good afternoon, everyone, and a very warm welcome to this midterm CME, most awaited. And due to the ongoing COVID-19 pandemic, we are yet again compelled to have a webinar and not any offline CMEs or conferences. So at the outset, let me give a very warm welcome to all the delegates, the faculty, the office bearers of Infectious Disease Chapter, and all the office bearers of my team, IAP Pune. I welcome our current president, Dr. Sanjay Nathu, who is also the organizing secretary for today's event. Over to you, Dr. Sanjay Nathu.
Yeah, thank you, Manisha, and a very warm welcome and a very good afternoon to all of you from Pune. So as Manisha rightly pointed out at the outset, at the start of the year, we had planned to have this physical CME and a big affair for 1.5 days. But unfortunately, because of the COVID situation, we had to compromise by going online. And now we'll be having this 1.5 days CME with all the esteemed faculties of very high academic stature, discussing very important problems in pediatric infections, starting right from the neonate till throughout the pediatric age group. So I welcome all the delegates, all the esteemed faculty for this CME for the next 1.5 days. And I wish a very happy learning experience to all attendees. And I'm sure it will add a lot of knowledge and give us new insights for our practice. So thank you and welcome all of you. Back to you, Manisha.
Yeah, thank you, Sanjay. And we'll begin with the first session today, which is a panel discussion on neonatal sepsis current approach. For the session, our moderators today are Dr. Anand Deshpande and Dr. Sandeep Kadam. And the panelists are Dr. Sanjay Aher, Dr. Mahesh Mohite, Dr. Sanjay Ghorpade, and Dr. Narmada S. So I will do a very short introduction of our moderators and our panelists. Is my screen visible?
Yes.
Yes, ma'am.
Yes.
Yeah. So I will start with Dr. Anand Deshpande, who is a consultant pediatrician and neonatologist at Dinanath Mangeshkar Hospital, Pune. He has been an examiner, a teacher, a guide. He is a past president of IAP Pune chapter, and he is ex and current executive board member of Central IAP. We have seen him as organizer of many national and state conferences, delivering many useful and solid content lectures. Next is Dr. Sandeep Kadam, who is a consultant neonatologist at KEM Hospital, Pune, with special areas of interest as neonatal ventilation and neonatal nutrition. He has published several papers in index journals and contributed to chapters in various books. And he has almost, he has not mentioned here, but has won many awards too. Next is our first panelist, Dr. Sanjay Aher, who is a neonatal intensivist and owner of NeoCare Hospital from Nashik. His areas of interest are neonatal ventilation and care of extremely low birth weight babies. He has done fellowships from Canada and Australia. He is author in 3 Cochrane reviews on erythropoietin and neonatal anemia, and has been organizing president of MahaNeocon year 2019. Dr. Mahesh Mohite, who is a pediatric and neonatal intensivist at Sai Child Care Clinic, New Panvel. He is president-elect of year 2022 IAP Intensive Care Chapter. He is a teacher, a guide, and council member in Pediatric Critical Care, India. Dr. Sanjay Ghorpade, very well-known figure in pediatrics. He is Director and Professor of Pediatrics, Postgraduate Institute of Pediatrics, Niramai Hospital and Research Center from Satara, Maharashtra. His areas of interest being pediatric and neonatal intensive care, pediatric infectious diseases, and pediatric pulmonology. Is a professor of pediatrics since last 15 years, a postgraduate teacher, guide, a national trainer for various IAP modules, and has written chapters in many books, especially on infection in pediatrics. The final panelist today is Dr. Narmada Ashok, who is a consultant pediatrician, director of Nalam Medical Care and Center and Hospital. She has won many awards. She is an eminent personality of pediatrics, associate editor of IAP textbooks on practical pediatric digest and management algorithm for common pediatric illnesses, has delivered many talks in many national and state conferences, has been a trainer for PALS and advanced neonatal courses, has journal publications, many journal publications to her credit. So I now request our panelists to take over and start the first session for today. May I request Dr. Anand and Dr. Sandeep Kadam to start the first session today.
Sandeep? Sandeep? Sandeep?
Sir, good afternoon.
One small announcement for the delegates. Kindly put all your questions in the chat box, and the panelists are requested to post their answers in the chat box, because in want of, if we fall short of time, we will not be able to take any question answer sessions.
Sandeep, shall I start?
Yes, sir, please.
Okay. Good afternoon, everyone. This is the first session of this midterm CME, well crafted by the ID chapter and Pune IAP, headed by Dr. Natu and Dr. Kulkarni. First of all, I would like to thank on behalf of both of us, Dr. Kadam and myself, for giving us opportunity to moderate this session, the opening session of this CME. Sepsis, as you know, is a quite old topic, but equally burning too, and will remain so for coming years. Neonatal sepsis, in peculiar, is particularly important because of the subtleness. There is a lot of overlap with the cardiac and metabolic diseases and its aggressive nature. And because of its aggressive nature, once it gets fully established, it has a very high mortality and morbidity. And for the same reason, because it has a very high mortality and morbidity, it is many times overtreated, treated, and sometimes overtreated. It is said that, or it has been, people have done studies that for every septic neonate that is treated, about 11 to 15 neonates who had been treated have a doubtful sepsis. So our aim in today's presentation is to know from our esteemed faculty who have worked in the work in the field of neonatology for many years. They have the cleverness and wisdom. They will be answering the FAQs, frequently asked questions, by the common pediatrician. So a lot of neonatal work in the field is primarily done by the pediatricians. So they are the torch bearer of the neonatology everywhere. So we want to get the answers to the FAQs of the pediatrician. At the same time, we also want to know about the rational antibiotic practices in the field of neonatology, so that how we can stop the overuse of antibiotic and can curtail it either while starting it or while stopping it or duration wise. So how can you have a rational antibiotic practice? These are the two aims of today's presentation. At the same time, we would like to discuss about the newer modalities to pick up the sepsis very early, as early as possible, and differentiate it from the overlapping conditions of metabolic disorders and other things, or the hyaline membrane disease and meconium aspiration, which may mimic like a sepsis. So at the end of this 40-45 minute session, we will be wise on these fronts, I suppose. So let us start without wasting much time. Now, I will start with the first question to Dr. Mohite. Sandeep? The first question is to Dr. Mohite. How will you suspect in the sepsis in neonate? Dr. Mohite, you are muted.
Sorry. Thank you very much, Pune IAP, for inviting me for this August gathering. Coming to your question, how will you suspect? Actually, before you suspect, there are some risk factors in a newborn to be considered for suspecting. So basically, a mother with a prolonged rupture of membrane more than 18 hours, or mother with a fever, with a UTI, with an infection of any kind, or foul-smelling liquor. This is a baby which is a high-risk baby for infection, especially if it is premature low birth, then the risk becomes much, much higher. On that background, or even without this background, if there is a history of meconium stained liquor, meconium aspiration, then it's twice the possibility of this baby catching up sepsis or hypoxia. One of the references says almost 36 times higher that this baby might have already been infected. So on this preemptive history, or even without this, if this baby develops a non-specific symptoms like a fluctuating temperature, hypothermia, or any kind of a lethargy, or refusal of feed, or decreased feed, or regurgitation, altered aspirates, those kind of things, or there is a disease or kind of a system-specific symptom, so tachypnea, distress, grunt, apnea in case of respiratory, or can be a cardiocirculatory failure, child develops a compensated or decompensated shock or altered color, or is having an encephalopathic presentation, so lethargy, refusal of feed, or hypotonia, hypertonia. So there are multiple. So I would say in one single statement, if you have specific symptoms of sepsis, as we all of know, or we have something symptom which is not explained by a particular kind of a disease, you always have kind of a sepsis on the background. So it would be kind of primarily kind of a presentation where a diagnosis of exclusion, but very likely to be kept in the mind, and a preemptive treatment or sometimes empirical treatment may be justified. So any symptom cannot be explained, or a symptom can be explained. Think of a sepsis in case of a term or a preterm baby.
Any fever in the neonate is the sepsis?
Hypothermia more often, but yes, hyperthermia certainly. If it is a fever more than 100.4 and which is consistently documented within 4 to 6 hours, always think of sepsis in this background, though you have to rule out other possibilities. So it can be a feature of sepsis. In a term baby, in preterm baby, it may manifest more of hypothermia in that case.
Okay, well said. The same thing what Dr. Mahesh has mentioned, we have summarized in one slide. So it has a multiple manifestation. Sepsis has a multiple manifestation. Next slide. Next question, Dr. Kadam, you're going to take on?
Sir, you can continue, sir.
Okay. So these are again common questions in the practice. You go to any cesarean section, or you go to for any delivery, you are told that this is a preterm with premature rupture of membranes. Leak is for more than 18 hours in mothers with a gestational age less than 36 weeks. So once the baby is born, will you admit this baby and start antibiotic, Dr. Godpade?
Yeah, actually, already Mahesh elaborated the risk factors. What are the risk factors in my baby? PPROM, that is, yes, my baby is a preterm baby, because whenever we are talking about the prematurity, definitely that is an immunocompromised host. With the history of high risk factor, that PROM, that premature rupture of membrane is there, it is more than 18 hours, it is well and good. But this baby we should treat aggressively. Number one, this baby must be admitted. Number two, whether to start antibiotic or not antibiotic. As per the antibiotic stewardship, what we are talking now, Yes, I will start antibiotic. Before starting antibiotic, I must do the septic screen, including culture, because septic workup is number one, but culture is important part. So before starting antibiotic, I will do the culture also. I will observe the baby for another 48 to 72 hours. In the mean period, I will assess for my reports. If the septic screen is negative as well as culture is sterile, very well, I can stop the antibiotics. This will be
So,
policy decision as per the antibiotic stewardship guidelines.
Dr. Gorpade, the culture, if you want to start antibiotic, we'll take the culture first and then you take the CRP and hemogram at that time, or you like to defer?
For septic workup to come positive, at least 6 to 12 hours interval must be there after the delivery of that baby. That is number 1 point. Number 2, before starting antibiotic, yes, I must take the culture and then I will start the antibiotic. Otherwise, I will not start antibiotic because that will change my reports and everything.
So if you decide to start antibiotic, there are two different samples you'd like to take. One is the for the culture, that can be as early as within an hour or so.
I will take the culture and I will start antibiotic, but after 6 to 12 hours, I will take the septic profile in terms of the CBC, CRP, then IT ratio, all the things after 6 to 12 hours. Why? Because CRP will take time to raise. That's why I will take it after 6 to 12 hours.
It comes negative then?
If the culture, if the septic profile is negative, still I will wait for the culture reports. Unless and otherwise my culture report is sterile, I will continue the antibiotics.
Okay, for maybe third or fourth day.
Yeah, after the 48 to 72 hours, because due to bacterial media, now we get the culture reports within 24 hours also. So I will take the correct sample of 1 ml in the bacterial media and I will send for culture and I'll wait for report for 24 to 48 hours. Once my report is sterile, then I will definitely stop the antibiotics.
Thank you. Thank you. Coming to another very common query, the same situation. Now here is a baby's term baby with a prolonged rupture of membranes. Now it is more than 24 hours. Will you start antibiotics and admit? And this baby is stable and feeding well. Dr. Ahir.
So half answer you have given in your question itself, that baby is feeding well, he doesn't have any symptom. So if you ask me, this baby doesn't need any antibiotics because this baby is well. So you should observe this baby, how the baby is taking feed. Is there any temperature instability and baby is well, there is no need to start antibiotic in this baby. But if this baby is unwell, if there is chorioamnionitis or fever in the mother, or any other risk factors like false smelling liquor, then definitely you can start antibiotic. But in this case, I don't think this baby need antibiotic because this is a stable baby and this baby is feeding well.
Dr. Ahir, is there any indication where you upfront start antibiotic without empirically antibiotic in a baby born without any investigation? Are there any such situations?
So we go for risk factors. Like if you have foul smelling liquor and if you have 2 or 3 risk factors along with that, like unsterile vaginal examination or maternal fever. So if you have those indications, then you can start. Or if baby is looking very sick, then you can start antibiotics. But just because there is prolonged rupture of membrane in term baby who is well looking, I don't think we have to start antibiotics.
Yeah. But if there is a strong, concrete evidence of amnionitis, you may start a foul smelling liquor is there. Can we start directly?
Still, if babies, we can do septic screening, wait for the reports, and then you can take a decision.
Okay, we'll
because
decide
this is a term baby. Because this is a term baby. There is no hurry. Like we can wait for the septic screening report and then start. But as I said, if baby is very unwell, then you have to start the antibiotic immediately.
Why there is a dichotomy like premature and term? Are there any studies behind that?
Because preterm babies are already at very high risk because they can develop pneumonia very early. Their immunity is poor. That's why we have different criteria for preterm and term babies.
And what about post-term?
Post-term same as term babies. There is no difference in term and post-term babies. They are considered as like full-term babies for that, as far as antibiotics and infection is concerned.
Thank you. Well explained, sir. Next slide, Sandeep. Now here is the preterm neonate with a respiratory distress admitted to NICU. Admitted to NICU on oxygen. And baby is having distress, probably RDS or something else, we don't know exactly. Would you require to start antibiotic?
Thank you so much. At the outset, I would like to thank Infectious Disease Chapter and IAP Pune for giving me the opportunity. Now coming to the questions, I would again reiterate back to the risk factors that are present. That first question answered by Dr. Mahesh Moitese was so important that we look again at the risk factors. Though preterm is considered as one of the, by itself, are prone more to sepsis, as told by the earlier speaker, still I will be looking into the other factors also. If it has been like a planned elective LSC taken for the maternal purpose and it's a clean like no other risk factors seen, no other factors, I would wait and observe this baby, because we know the respiratory distress in the preterm could be due to multiple other causes. So we can wait and see. When there are no risk factors, I would not straight away start on antibiotics. But if it has been due to a premature rupture, or if there is risk factors, maternal risk factor, if the child appears, baby appears unwell, I would straight go ahead and start. But in this condition, I would require more history, wait up, observe the baby, and then decide. Definitely, I would not start on antibiotics right away.
If baby requires intubation and ventilation, then
again we could look out the causes for why it
now our diagnosis is that it is a respiratory distress syndrome,
yes,
or Highland HMD. And we require intubation and ventilation, or we are given surfactant, we have done some invasive procedure. Will you go for the antibiotic or will not go for that?
I would.
Anybody else can also, all others can also give input.
Yeah, actually, per se, if you are confident about the aseptic precautions and everything, really on the ideal ground, we should not give the antibiotics.
No. I have some different. I mean, we get references from n number of centers, and we know certain centers how they practice, and so I get baby from say civil hospital, then I'm slightly having low threshold for giving my antibiotics. I'm getting it from a good gynecologist, my threshold is slightly higher. And then because that's additional factor we have to take. Again, the transport, we pick up the babies from 100 kilometers with a CPAP being given there and transported, my threshold to give antibiotic will be low. So these are preterm baby, which is having slight fluctuations in or behaving slightly unexpected way. You started CPAP, requiring higher CPAP for him initially and not responding to a surfactant immediately. Perhaps my threshold is antibiotic. So I think these are baby to baby.
Other the factors.
And if I say,
one of them had asked,
Dr. Sandeep, you just give your inputs on this topic, because this is a debatable topic. So
I think we can carry on for the entire day with issues of giving and not giving. The bottom line here would be, if you have a plain RDS with prematurity, there is no need to give antibiotics. If you have a risk factor or clinical suspicion of infection, then I think we are more scientific in giving antibiotics. Obviously, the local factors come into a big way. Like if a baby is retrieved from 100 kilometers, I think there would be a reason to give antibiotics. But per se, RDS or TTN, I would not give antibiotics. And obviously here we would see if a baby, it's always very difficult to differentiate RDS from congenital pneumonia. And in those cases where you have features of infection like asymmetrical lung disease, you have early appearance of shock, a prolonged CRT, a baby who is foul smelling, umbilical cord, or there are pustules, or there is eye discharge, there is skin pustules, then in those cases you would definitely be more scientific and logical in giving antibiotics rather than waiting. So I think we have to balance wisdom and science and then decide about antimicrobial.
Individual case basis and the reason for why it was a preterm, all that will definitely give us.
But the message that we want to give here would be that plain RDS is not an indication.
Not an indication for
plain RDS requiring ensure is probably not a case for antibiotic. Next slide. Again, similar situation, a term baby with mass admitted with tachypnea.
So shall I take this now?
mass admitted for tachypnea and distress. Role of antibiotic. Mahesh.
Again, as I told you, this being a risk factor, having almost like up to date gives almost 2 times the higher risk of infection in case of meconium aspiration without defined other risk factors which you already discussed in the first slide itself. So here, definitely this baby has a higher chance of having underlying infection. So your threshold for starting antibiotic in this baby should be low. You will be giving whatever treatment required. But if there is in first 6 to 8 hours, if it's rapidly progressing, there are some instabilities in hemodynamics coming up, my threshold to start antibiotics will be definitely higher in this child. Otherwise, just because meconium aspiration, again, it's a chemical pneumonia, there is no role of antibiotic. But if you ask me how many of my meconium aspirations I got them without giving antibiotic, perhaps that may be about say 20 or 30%, 60 to 70% of time, those severe one, moderate to severe one, at some point of time, I had to start antibiotic. So that's my take on this.
So initially don't start. You initially don't start, and as you get signs and warning signs or inflammatory markers or CRP or
no. Again, inflammatory marker. Inflammatory marker is a very gray zone here. Inflammatory markers will be extremely high initially. So if you want to follow up, continue to have the same inflammatory markers, so they are rising. Maybe after 48 hours, I will be prompted to give it. On day 1, my CRP may be 100. I will not start just based on that. So I have to be very careful defining inflammatory markers. A normal baby and meconium are totally different stories here.
No, so right here, can you tell me what are the reasons other than the infection of rising CRP in neonates? So I mean, they are giving false sign first.
So any kind of a stress, if say CRP just a stress manipulator. CRP, if you see 5% of them are having really, if you have taken isolation, only 5 to 10% of them have a sepsis. So it has more of a negative predictive value than a positive predictive value. It can be high in meconium, it can be high in a HI baby, it can be in any stress, even a normal delivery you take, I will find few babies who are having higher CRP. So CRP really doesn't mean in isolation to me. So meconium certainly that's being one which a higher CRP. If it is negative, then I'll be more worried on the contrary. If it is positive, it's something which goes with my routine meconium aspiration. CRP is not really an important factor.
So for negative predictive value, you require single CRP or double, two CRP?
See, again, you should not take it in isolation. It has to be a complete septic screen. If all are negative, then it has got almost 100% negative predictive value. If it is in isolation, each of them are having 5 or 10%, 2 or 3 factors, maybe 25%. It really doesn't mean anything. It really doesn't mean anything. Yes, if it is coming 2 or 3 factors, I will be starting empirical, preemptive kind of antibiotic, but I'll confirm it my cultures and subsequent trending. Trending will be important. If my first day CRP is 100 and third day is maybe 10, then I have good reason to stop it if my cultures are also negative.
Okay.
And that follow-up CRP, follow-up septic screen is important after 48 to 24 to 48 hours. If that is a negative, definitely it has got good predictive.
The literature says 2 CRP 12 hours apart. Negative as a 95-98% capacity to predict against sepsis. Next slide. A newborn with fever comes to pediatrician. How will you decide as regards to doing septic workup and starting antibiotic, or observe or do nothing?
So in this case, we will have 2 scenarios here. Baby is having fever, but baby is well. So we have to check what was the baby's birth weight and what is the weight of this baby today. Whether this baby has any weight loss, whether he has any signs of dehydration, and which period of the year this if it is a summer period, then there is very high chance that this may be just because of high environmental temperature, this baby is having dehydration and having fever. So such type of baby will not need antibiotic. We have to correct his dehydration, take care of the temperature. The second scenario where the baby is having very high and persistent fever, and if you are having core to peripheral temperature difference, then definitely this baby might be having some infection. So we can do septic screening and start this baby on antibiotics.
Okay, so that is the way we differentiate between the environmental fever or maybe dehydration fever from the other things. That is the only way to differentiate between environmental fever and sepsis.
I said there is a core to peripheral temperature difference will be seen with sepsis. Will not be seen with dehydration fever.
Another differentiating point here that I would like to add would be to look at the posture of the baby. If you have a baby with fever and extensor posture, it is more likely to be environmental fever. If you have a baby with fever and flexed posture, it is more likely to be infection. However, fever which is persistently high, that is more than 38, lasting for more than 1 hour, please start antibiotics, don't wait. You need to rule out infection in this particular scenario.
Okay. Next slide, Sandeep. A day 10 neonate with a lethargy, day 10 neonate with lethargy, refusal to feed and diagnosed as a late onset sepsis. Will you do LP and urine culture, both? Which antibiotic will start? Dr. Sanjay?
Yeah.
Gurpade.
Yeah.
Two
Sanjay sir there. Late onset sepsis is invariably associated with many times with the meningitis. I think more than 20% cases and literature shows more and more cases of the meningitis associated with the late onset sepsis. So lumbar puncture or CSF examination is must. Why? Because two things are important. Choice of antibiotic changes, because if the CSF or pyogenic meningitis you are suspecting or bacterial meningitis you are suspecting, the choice of antibiotic which will be penetrating the CSF. That is number one. Number two, the duration of antibiotic will changes. That's why many times actually we are not doing the LP and these babies will end up with the hydrocephalus in future when it happens these things. So late onset sepsis, CSF is must, number one. Number two, what about the urine culture? Urine culture, many times actually underlying cause of the late onset sepsis may be urosepsis. So routine urine culture and CSF, actually we must go for the whenever you are suspecting late onset sepsis. Second question was about the starting antibiotics. Definitely late onset sepsis, as per the local antimicrobial flora, I will start antibiotic. I am starting usually ampicillin with the gentamicin. Before that, I am sending the culture and all the things. After the culture reports, I used to change my antibiotic policy. But if your baby is sick enough and you are suspecting the MDR bugs, here we must be a little bit more aggressive. In that case, definitely the choice of antibiotic will differ in terms of the aminoglycosides or carbapenems. But here, message I want to give that as far as possible, avoid cephalosporin. Why? Because many times it induces the multi-drug resistance, especially if you are suspecting the ESBL producing organisms. So definitely this is a one important message. Yes, CSF we must go if you are going for the late onset sepsis.
So once you decide to avoid third generation cephalosporin for the apt reason of ESBL production, what remains is carbapenems only.
Yeah, carbapenem.
None of the other antibiotic is going to penetrate CSF.
Definitely, sir, because piperacillin tazobactam doesn't crosses the blood-brain barrier. So that is not a good antibiotic choice, even that it is sepsis. But if you are sepsis associated with the meningitis, the drug of choice, if you are suspecting the MDR bugs, ESBL producing, definitely the drug of choice will be the carbapenem.
What should be taken as the cutoff of the cells, and what precaution to be taken while sending the sample to the lab?
Basically,
this is a practical question for our pediatrician.
Yeah, 20 cells will be the cutoff. And what type of cells? It should be lymphocytes. If they are polymorphs, then again the question will be different. So up to 20 cells, we can say that that could be a normal CSF.
Mahesh, you want to add anything?
2-3 points here. The point is on the cell. My threshold is more for the sugar. The comparison of blood versus a CSF sugar. I get a significant hypoglycemia, then I'm more having proteins being very high, more than 150 will be significant. But when you were talking about late onset sepsis, not to forget the literature says 70% of the sepsis in late onset will have some infection in the CNS. But what about the early onset sepsis? Do you mean to say you will not do the CSF in case of early onset sepsis? If you get a definite sensitivity pattern, a culture proven, bacterial proven, then CSF is absolutely mandatory, even in early onset sepsis. I mean, even if it is 10% possibility, do you want to miss out on that? So even in the early onset sepsis, CSF is definitely mandatory, I believe. Once you confirm sepsis is there, you have to do a CSF just to ensure that 2 or 3 weeks of antibiotics are properly chosen. And about a cell cutoff, again, there are no definite guidelines. Multiple book mention a preterm up to 32 is normal, term up to maybe 10 or 20 is normal. We really don't know the number. So let's not go by number. You have definitely more than 50. You're sure about it. When you're on 10 and 20, you're doubtful. You may follow it up. You have to preemptively treat it as bacterial meningitis. And there perhaps sugar comparison CSF will be very important. Proteins which are more than 150 will be reasonably ready. Whether it is neutrophil lymphocyte, we really don't know anything about it. And Sandeep or even Sanjay or Narmada or Sanjay, you can give me comment. I am not sure about this number and lympho and.
More so in our practice, sir.
I think
your opinion, Sandeep.
CSF, I think CSF should be actually interpreted in toto, not only the cell count, not only the sugar, not only the protein. So all factors should be taken into consideration. Then we should interpret the CSF in neonatology, especially bacterial meningitis if you are suspecting neonatal.
More so in places like us, where it is a tier 2 city, the labs, we are relying on the lab, the cells count we cannot make out, rely more on sugar and protein. That gives me an immediate thing to start the antibiotics there. So I rely more on the sugar and this.
One more point here about the sugar. If you are taking the sugar, CSF, blood sugar also is important, because if that patient is hyperglycemic, sugar value again differs.
Yeah, make it as a mandatory and protocol to take the sugar value and this one, WBCs also at the same time.
Sandeep.
So I think we all agree that there is a lot of controversy about diagnosis of meningitis based on CSF. So the bottom line probably is that look at the complete picture rather than just cells and just the proportion of polymorphs. But by and large, anything more than 30 cells is something which is going to arouse you that this is probably meningitis that we are looking at. And secondly, whether we have done antibiotics before giving CSF before giving antibiotics, or you have waited for the culture and then you have done CSF. I think these are few things which come in the way, because quite a while, if a baby is sick, the first thing that a referring doctor would do is to give a dose of meropenem and then refer the patient to higher rate. So we need to look at that picture and not miss out on meningitis in newborn babies, because it can be detrimental, and we have seen a lot of problems.
And these are the bottom line is do an LP. That is more important, because many of the time practitioners hesitate.
Do an LP and send a culture.
Do an LP, do a culture also. Both.
And also do a gram stain.
Another
gram stain.
The take-home message is if you have early onset sepsis with culture positive, do LP. If it is late onset sepsis, along with culture, you do LP also. I think that should be the take-home message for the pediatricians.
I think we have only.
Sorry to interrupt all the panelists. Hello, you have only last 10 minutes, please.
Okay, we'll try and finish. So the CSF should reach the lab within 2 hours. That is generally mentioned in all the literature. So this precaution is possible in big hospital, but there is little. Otherwise, you have to inform your pathologist while you are doing your CSF and be ready. Sandeep, will you take the next question?
So I will start, sir. Is blood culture important and mandatory in all babies before starting antibiotic, Dr. Narmada?
Yes, sir. Definitely, very, very important. That's what I said even in the earlier thing. The culture of taking a culture has to come for all of us, sir.
Excellent. So blood culture is mandatory to send 1 ml of blood with backtake or back alert and early transport and increase the yield, because in the best of the best centers, the yield is not more than 15 to 20%.
Yeah. And one more problem with transport, what we do here is they do the plating in the place. If they're not having, they can do the plating and then they can transport it also, or use a safe thing. That will be much better for us for
Madam,
transport.
We have only 10 minutes. Now just be very quick in answering very specifics. Dr. Moite sir, what is sepsis screen and role of sepsis screen in neonates? We have covered a bit, but
sepsis screen is all. List is unending. The CBC, total count, IT ratio, micro ESR, CRP, procalcitonin, and the list will continue more and more. What is important? Some of these markers in isolation are important. It has to be taken in toto, and negative predictive value is 100% or maybe next to 100%. Single product or single issue, positive predictive value is very poor. Even a CRP has a predictive value of only 5 to 10%. So forget. And whether it is procalcitonin, again, we have seen a lot of issues related to procalcitonin. Though we say differentiate between virus and bacteria, in COVID we saw procalcitonin going to 100 at times. So we really don't know what is final of it. But perhaps we conventionally accept more than 10 of procalcitonin, probably likely to be bacterial. But what about 2 to 10? We don't know. So let us take it. Negative predictive value of all septic screen is very high. Positive predictive value in doubtful. But one more thing, trending is important. If you see a trending every 2 to 3 hours through 2 to 3 days, perhaps that can tell you whether the bacterial infection is decreasing or not. That's how we will take on that.
I think the message here is quite clear. Don't use septic screen to diagnose infection. Number 1. And number 2, use sepsis screen 24 to 48 hours, 2 sepsis screen to stop antibiotics. If the sepsis screen is negative, you have ruled out infection and not ruled in infection. Sanjay, role of prophylactic antibiotics and word on antibiotic stewardship.
So there is no role of prophylactic antibiotics in NICU. You should not start the baby on antibiotic just because baby has come to NICU. So no to prophylactic antibiotics. And just about antibiotic stewardship, it is all about when and to whom antimicrobial agents to be started, which antimicrobial agents to be started, and how. What should be the dose, duration, the route. And we should have continuous monitoring of these babies and their antimicrobial use. And we have to use all the resources and resources for education of the team who is looking after the babies in the NICU.
So again, the bottom line would be to use less antibiotics, narrow spectrum, and stop as early as possible rather than be on a threshold to stop antibiotics as far as NICU is concerned. Because once upon a time, neonatology and NICU was equal to antibiotics and sepsis. So I think we need to get out of that stigmata. Sanjay, Dr. Sanjay Ghorpade.
Yeah.
Neonates with umbilical discharge and induration, how will you manage?
Probably it is
antibiotics.
Probably it is umbilical sepsis. We should not take it lightly. That we should be taken as a serious condition because definitely the organism will spread in subsequent part. So here the definitely cleaning of the local part of umbilicus, and I will choose the IV antibiotic. Why? Because the umbilical sepsis causes the poor hygiene, and many times it is common in poor socioeconomic status. The staphylococcal infections are quite common with the umbilical sepsis, and if I want to choose the antibiotic, I will see that narrow spectrum community acquired staphylococcal antibiotic cloxacillin may be the beneficial, and if clox is not available, then cefazolin IV will be the another option for the treating the umbilical sepsis with the IV antibiotics.
Mohite sir, any comments?
I think that is reasonably. First of all, this child will require IV antibiotic for at least 3 to 5 days, and subsequently one can shift on to oral if the baby is doing well.
So no role of oral antibiotic and no role of topical antibiotic, no role of antibiotic. With pustules.
Okay.
Can I use oral antibiotics?
Sir, it depends on the number of pustules.
So Deshpande sir, you wanted to say something?
No, I want in a whale baby, only local to a few drops of pus in the umbilicus. Are you going to give? This is a common situation in the pediatric practice. Because they put some oil or something, you get some 1 to 2 ml.
I purposely said there was induration, sir.
Induration was there. Induration was there.
If there is only discharge, it is a different issue.
1 or 2 ml of local pus need not have an IV antibiotic, or should not. That is my opinion I wanted to ask from you.
No, I will give an antibiotic. I will definitely give the first choice antibiotic. If they have their constraint, then that's their choice. But my choice.
Not antibiotic, oral or
oral. IV. I'm saying IV. Yes, first 48 to 72 days IV only. Till I see
Sir, here is the chance of the getting the necrotizing fasciitis and subsequent.
Last 3 minutes, please.
Can you give us some attention? 5 minutes, if possible.
Yeah.
Yes. Along with that,
multiple pustules straight away. It depends on the number of pustules, condition of the baby, how sick it is. So if it is less than 5 pustules, maybe topical. More than 5 pustules, baby not sick, then probably think about oral. But if it is the sick baby, directly treat it as a sepsis only. So I'll go ahead and treat it, knock it hard.
Mohite sir, platelet count of 26,000 day 1. Do I need to start antibiotics?
It depends upon again the sick baby, non-sick baby.
No, baby is well. Baby is well.
Baby is well. No predisposing factor, no risk factor.
No risk factor.
No, then no need of antibiotic to this baby. You will monitor the baby.
Excellent. So look at the mother, probably PIH or TORCH or HELP or immune thrombocytopenia.
IUGR, even a plain IUGR can have that number.
Gestational thrombocytopenia. Sanjay, role of clinical examination in diagnosis of sepsis.
Very, very important, because clinical examination is very important, because your lab screen will take some time to come. So you have to be very vigilant to see whether that baby is looking sick or unwell, whether baby is having fever. Is there any temperature difference, 4 to central temperature difference? Then scleroderma, whether baby is in shock, baby is having any discharge from the umbilicus, which already discussed, any pustules. baby is having, how is the baby's frontal end, whether baby is having petechiae porphyria. So these can be signs of very serious condition in the baby. So clinical examination is very, very important.
So I think we all agree that it's a clinical diagnosis. Sepsis is a clinical diagnosis. Some rapid fire questions for all of you now. Sanjay Gorpade. Sanjay, role of IVIG in sepsis, yes or no?
No, not at all.
Procalcitonin in sepsis, when do we do? Dr. Namad, I think we have discussed with Dr. Moite, sir.
Sir, if it is available and the patient is affordable, then, but definitely routinely in private practice, we are not using, we use more of
So
the
it's
other.
very expensive. We are not.
Yes, we are not using routinely. Yes.
Prophylactic antifungal in preterm babies.
Again,
Dr.
it's a
Narmada.
no, but if there is a high-risk baby, invasive central venous is there, and if your unit is reporting more than 10% of by fungal culture, this baby is a sick baby for a prolonged time, then I will think about it. Otherwise, routinely, I will not start right away on prophylactic antifungals.
Sanjay, duration of antibiotics in risk factor based approach?
48 hours till I get the report and I'll observe baby. My baby is well looking and negative culture reports and negative all the things. Definitely, I will stop the antibiotic after 48.
In a preterm baby, you would give. In a term baby, you can observe.
Yeah.
Duration of antibiotics in probable sepsis, Moite sir?
So till the time you get a septic screen, culture definitely will continue. At the end of it, if the septic screen is positive and culture is negative, maybe 5 to 7 days. If the culture comes positive, maybe 14 days, and CSF come positive, maybe 3 weeks. Probable sepsis at that point of time, you're definitely defined to give for 3 to 5 days since you have got a septic screen positive.
Duration of antibiotics in proven sepsis, Sanjay, I think we have covered this 2 weeks.
Sandeep, we'll have to stop. It looks like
Yes, we are running out of time.
Okay, fine.
So, finish
shall I just cover this or I'll finish?
You cover this.
Okay. Last 1 minute. We this is rapid fire. So just
Sanjay, duration of antibiotics in proven sepsis?
5 to 7 days. If it is culture positive, then you give for 14 days.
Moite sir, antibiotics in meningitis, you've already told us 3 weeks.
At least 3 weeks. And if there is a complicated meningitis, maybe 6 to 12 weeks.
Sanjay Ghorpade, antibiotics in UTI duration?
10 to 14.
10 to 14. Probiotics in newborn, Sanjay?
Latest guideline doesn't recommend probiotics in neonates.
Okay, good. Risk factors and neonate, I think we've already covered this.
Yes, sir. This one, like up to 48 to 72 hours.
Okay, fine. So I think we have covered majority of the issues. Before we end, I think there was a word about biomarkers in sepsis and PCR, newer markers for early onset and late onset infections have come a big way, and probably in the next few years we are likely to see CD64, interleukin 6, pre-sepsin as promising factors in diagnosis of infection. PCR has high sensitivity and specificity, very quick. But currently, it is using 16S RNA and it is research based. So before we end, I think we still have to look at the baby, look at the heart rate characteristic changes, core to peg temperature difference, and use your wisdom and clinical acumen to diagnose infection and use sepsis screen to rule out infection. So last word, 2 pearls per panelist for everyone for neonatal infections. Moite sir.
Yeah, I think prevention, if you get a sepsis of a onset or late onset, then think whether there is something missing in the NICU, one. And second, in next 2 years, don't forget the sepsis mimic of MISN. We are seeing few cases, but we're likely to be flooded with cases. Don't forget the important differential diagnosis of sepsis in future.
Sanjay Ghorpade.
Hand washing, and no prophylactic as far as antibiotics in the NICU.
Excellent, very good. Sanjay Aher.
So you should have a culture of sending culture. So before you start or change antibiotic, you must send culture, and you should have courage to stop the antibiotic when the culture is negative.
Very good. Narmada madam.
Yes, for private practitioners, don't start antibiotic for all cases of meconium aspiration or preterm. Please wait, rational antibiotic practice, and don't start empirical in the clinic. If you have a doubt, please refer.
Deshpande sir.
And almost all points are covered. I think
your words of wisdom.
hand washing is the main, and I think due to COVID, people are in the habit of hand washing. So we'll have to have one study whether COVID has decreased in NICU sepsis because of the hand washing practices.
And they wash hand outside, may not be washing in the NICU. They wash their hands outside. I don't know whether they do it in the NICU.
So before we end, I think on behalf of Deshpande sir and the organizing team, we would like to thank all the panelists for their excellent inputs and suggestions. And I'm sure we have given you all have given us a lot of wisdom, which we can change our practices in days to come. Thank you, one and all.
It was definitely rapid fire, Dr. Sandeep.
So we had no time.
Thank you.
Thank you.
Over to
Sandeep,
the organizing
thank you,
committee.
Anand.
Thank you so much.
Thank you very much. Thank you.
Yeah,
Sorry for
thank you.
exceeding- Sorry for exceeding by 5-7
So we
minutes.
started 10 minutes late, sir.
Okay, whatever remains is for the next season, season 2. We all, because of
Better.
web series, now we are all used to getting seasons after seasons. So we'll have the
Physical
remaining
version, madam, not the virtual
yeah.
one.
hopefully, yes. God bless. Okay, thank you all
Thank you.
panelists.
Stop sharing your screen, Sandeep. Okay. Thank you.
It was an excellent session. Thank you, moderators. Thank you, panelists. We move on to our next session. We are running a little short of time now. So without wasting any more time, I will start the next session, which is talk by 3 eminent pediatricians on various topics which are clinically important. So the heading that has been given is Alert to Art Learning from the Masters. And we have chairpersons, Dr. Prabhas Giri and Dr. Satish Sharma. And we have 3 topics today: viral hemorrhagic fever by Dr. Rita Brata Kundu, complicated chickenpox by Dr. Kukreja, and this acquired encephalitis by Dr. Chitkara. So I will just give a very short introduction of our panelists. Just hold on 1 second. Is the screen seen by everyone?
Yes. You can see Dr. Prabhas.
Yeah. So Dr. Prabhas is an associate professor of pediatrics and in charge of PICU of child health in Kolkata. His areas of interest are pediatric intensive care infections, and pediatric infectious diseases. He has more than 50 papers to his credit as publications in indexed national and
We cannot hear you, madam.
You're not audible.
Yes. Madam, you're not audible. Hello.
Anisha, madam, you're not audible.
Hello.
I think there's some problem with the connection.
Deepak, can you take over? Just give me half a second, I'll take over.
Is there anybody from the DG Plus or DG?
Yeah, I'm just doing it. I'm just doing it. Give me half a minute. Manisha madam, can you stop screen sharing? Piyush, are you there? Piyush? Deepak, are you there? Deepak? Hello, Deepak?
Problem?
Deepak?
Sanjay, what is the problem?
Madam is not stopping screen sharing. Unless she stops, we cannot go ahead.
No.
Yeah, I'll just share the screen and go ahead now. Just a moment. Can you see the slides?
No. Dr. Sanjay is sharing the screen. It seems he's written at Dr. Sanjay, right?
Yes,
Now,
Yeah, I'm sharing the screen. Can you see the slides now?
yes, you can see.
We'll proceed to the next slide.
Yeah. So the next chairperson is Dr. Satish Sharma. He is MD Pediatrics, FIACM, FIMS, and FIAP. He is the medical director of Arcus Super Specialty Medicine in North Delhi and NCR. He is the EB member for CIAP 2021. He is also the EB member of National Infectious Disease Chapter 2021. He is also the Joint Secretary National Medical Legal Group. Our first speaker is going to be Dr. Rithibrata Kundu. He is the professor of medicine, pediatric medicine at Institute of Child Health, Kolkata. His areas of interest are infectious disease, and he has been the past chairperson of IAP ID chapter. He's also been the
I think that much will do. You don't have to say anything.
Okay. Right, sir. I'll just introduce the next two speakers as well in a short while. So the next speaker after Dr. Kundu sir is going to be Dr. Shyam Kukreja. He is of course MBBS MD Pediatrics. He is currently the director and head of Department of Pediatrics, Max Super Specialty Hospital, Delhi, and consultant pediatrician and specialist in pediatric infectious disease and immunization. Past chairman of Pediatric Infectious Disease Chapter 2018. The third speaker in this session is going to be Dr. A.J. Chitkara. He is currently the director and head Department of Pediatrics, Max Super Specialty Hospital, Shalimar Bagh, Delhi. His areas of interest are pediatric infectious disease and vaccinology. So I think with this we can go back to stop sharing, and Kundu sir can take over for the first talk. The chairpersons can interact with.
So first the chairpersons will say something, or I will start?
I think you can start, and after their talk the chairpersons can
start directly.
Achha, then I'll share my screen then.
Please.
So am I visible and audible?
Your screens are not visible.
Screen is not yet seen.
So I'll do it again. Wait. Shaking and sharing.
So please share your screen.
Now?
No.
Now? It's not seen.
No.
Hey, Ronnie, share the screen. Share এখানে share করতে হবে। Sorry, এখানটা করতে হবে share, I forgot.
আচ্ছা পাঠালি
ওটা খুলতে হবে আগে প্রেজেন্টেশনটা খোলো।
Yes.
Now I can see.
Yes.
So good afternoon, everybody, and it's a great pleasure to have one of my students who has now become a colleague, Dr. Prabhash Porshungiri, as one of the chairpersons. And in fact, some of the photos in this presentation is only given by Prabhash. So with this, today my topic is viral hemorrhagic fevers, but these are etiologically diverse virus infection united by a common pathophysiology. Most of the cases give rise to very severe febrile syndromes, often with multi-organ failure. At times, because of the vascular damage, you can have bleedings. And fortunately, bleedings are usually minor in most of the times, but serious life-threatening hemorrhage can also occur. So there are four families of virus which causes this viral hemorrhagic fever. The arenavirus is responsible for Lassa fever, and it is not seen in our country. The filovirus is cause Ebola, which is a deadly disease with very high case fatality rate in Africa. Hantavirus belongs to the Bunia group, and it causes viral hemorrhagic fever with renal syndromes. Few cases has been reported from India, even a case from Mumbai. Fortunately or unfortunately, I have never come across a case of hantavirus, and I don't think I'll be seeing such cases in the future also. The main contribution of viral hemorrhagic fever is the flavivirus. There are two important flavivirus which is there in our country causing hemorrhagic fever. One is Kyasanur forest disease, which is seen in the state of Karnataka, Bandipur Forest Reserve, a famous tourist forest spot. And dengue, which all of you know. Dengue is almost a monsoon menace which is occurring every year in this country. And it is very important to recognize it. The main pathophysiology of this group is that it causes increased vascular permeability, which leads to two very important things. One is capillary leak giving rise to shock. And in the organs where this leak or hemorrhage is occurring, it will give rise to organ dysfunction. As I've told you, hemorrhagic manifestations are usually in the form of petechiae, purpura, nosebleeds, gum bleeding, but serious hemorrhage like gastrointestinal hemorrhage can also occur. The increased capillary fragility test is the basis of tourniquet test, which is a very important test in places where laboratory facilities are not there. And as I've told you, that control of dengue, I don't think is not possible in the foreseeable future because it is virtually impossible to control mosquitoes. So the only way which you can save your patient from dengue is pick them up early and treat them early. So of the flaviviruses, the last three are usually seen in our country. They are very characteristic type. They usually start with a systemic febrile illness, very non-specific, but there are certain subtle clues in this systemic febrile illness where you can pick it up, and then thereafter they manifest their clinical forms, whereas dengue and Kyasanur forest disease will manifest as hemorrhage. Japanese encephalitis manifests as encephalitis, and rashes are seen only in dengue and Kyasanur forest disease. So with this, I come to my case. A 3-year, 11-year-old male child presented with headache for last 3 days. No cough, no pain, no loose stool or vomiting. He doesn't have a blood vision or altered sodium. There was no hepatosmegaly, but he has a reddish flush over the face and tongue. There was no respiratory chatter in the form of running eyes or nose. If you see the picture carefully, the whole face is red, the conjunctiva is red, the lips are red, the neck and the limbs are also red. So this is a scarletiniform rash, which has involved the entire child. This is another case who is 2.5 years old, has come with 5 days fever, extremely irritability. And if you see, this child also has a flushed face. His bulbar conjunctiva is red, his lips are red, the tongue, if you take the trouble to open the mouth and examine, the whole mouth shows evidence of mucositis, that is cheilitis, angular stomatitis, and also the limbs, that means the hands and feet are swollen and disformation. I don't think you have any problem in diagnosis. This is a case of Kawasaki disease, which might resemble our dengue. This is another 6-year-old child who has come with a sore throat and fever. After 3-4 days, the child has developed a flush, which is scarletiniform rash. And 3 days after the scarletiniform rash, the child started showing discommotion, as you can see here. The discommotion is most prominent in the skin creases, axilla and the elbow. And this is the case of scarlet fever, where amoxicillin given for 10 days will not only reduce the morbidity, but also will reduce the chances of developing rheumatic fever late. This is another child who has come with not exactly with the scarlatiform rash, but he has come with the maculopapular rash involving the face. His palms and soles were also involved. The child had a hacking cough. Though it is not seen in this picture, the child had running eyes and running nose. So this is a case of measles, which also resembles dengue. But the difference between dengue and measles is that dengue is dry measles. Skin manifestations might be just like measles, but it is dry. There will be no running nose, there will be no running eyes. Cough is not there, at least in the beginning, that much cough. So my child, who has come after 4 days of fever, which the examining physician could not pick up what was the reason of this fever, started with anti-allergics and antibiotics. He developed a petechial rash on the trunk and an subconjunctival hemorrhage in the eyes. So this is a case of dengue, which is going into dengue hemorrhagic fever or entering the critical phase, usually after 4 to 7 days. So this is another child who has fever for last 7 days, high fever. The child is not responding properly, irritable. This child has a rash, which is not exactly a scarlatiform rash, but it is a maculopapular annular rash. His eyelids are swollen and red. Also, he has a red lips and he has subconjunctival hemorrhage. So this is a case of multi-system inflammatory syndrome in children you see these days following COVID. IVIG and methylprednisolone, if given in proper time and proper supportive therapy, is going to save this child. This is another child who has come with fever for last 5 to 7 days. And initially, there was only undifferentiated fever without any finding. The child didn't have hepatosplenomegaly, neither the child had lymphadenopathy. And on the 5th day of the fever, round about 5th and 6th day, he initially started with having petechiae and purpura. Thereafter, the skin bleedings have increased. And nobody took the trouble to examine the angle of the eyes. Here you can see an scar. So this is the scrub typhus, which can be a very important differential diagnosis to dengue. If the child is given doxycycline in time, you're going to save the life of the child. But more late you are, more chance the child will go into irreversible stage. This is another disease which forms a very important differential diagnosis. They usually present with non-specific symptom, high fever, irritability, not eating properly, and at times they might have convulsion, they might not have convulsion. There is no organomegaly, and initially they will develop petechial and purpuric rash. And the progress of the disease is very fast. Even within hours, they can develop serious screen bleeding, which later becomes purpura fulminans. And you have to diagnose them early. A simple penicillin or amoxicillin or ceftriaxone is going to save the child from meningococcus. So these are the few important things which you have to think. So coming to the most common hemorrhagic fever which we come across our country is the dengue fever. It is one of the 17th neglected tropical disease, and for last few years it is affecting our country every monsoon, and the infection is rife almost everywhere in this country. As you all know, there are 4 types of dengue serotypes, 1, 2, 3, 4, each being able to cause a disease. And it consists of an RNA virus. It consists of a very important structural protein known as NS1 antigen, which is helpful in the diagnosis of the disease. Does one strain give cross protection to others? No. You should remember you can have more than one attacks of dengue. Dengue does not give any protection. Natural infection does not give protection. So this is a very important point to remember. The disease is transmitted by Aedes mosquito. The Aedes mosquito has a peculiar habit of breeding in artificial containers like broken flower pots, broken bottles, unused tires. And once they emerge from the larval stage, they stay close to their place of birth. They are not a long flyer. So it is the man or human being which transmits dengue from one place to another, not the mosquito. You should remember this very important thing. So there are certain risk factors which you should remember. Extremes of ages, infancy and old age, the chances of dengue is very severe. Previous infection, if you have an infection, primary infection with single dengue virus, your body will produce antibodies against the major antigen of that serotype of the virus. When you are subsequently infected by another serotype, the body, instead of producing antibodies to the new antigen which is possessed in another serotype, it will produce antibodies against the first one. So your protection against the disease will be poor and you will have a severe infection. This is also known as original sin. If the child has a secondary infection, then the morbidity of dengue increases. There are certain comorbid conditions. One of the most important comorbidity is obesity. And there are other genetic factors, and the virus strain 2 and strain 3, serotype 2 and 3, they usually cause more of dengue. So you should remember that chota dengue and mota dengue, these are the two types which usually leads to very serious dengue. So this is the spectrum of clinical manifestation of dengue. If you move to the right, the spectrum increases. To start with, you can have undifferentiated fever, then classical dengue fever, then dengue hemorrhagic fever, and dengue shock syndrome. But this classification no longer holds true because at times it is very difficult to place the child in this classification. And also, if you want to do study of antivirals in dengue or vaccines in dengue, then this does not provide a suitable endpoint. For these several reasons, this classification has now been removed. I'll come to the newer classification. Usually in undifferentiated dengue fever, it is only a mild to moderate fever. Rash may or may not be present. There is no plasma leakage, no bleeding. The pictures are shown. These are the common skin manifestations you can have. Coming to the next is the dengue fever. Here it is just like undifferentiated fever, but you will have certain important things. One is headache, retroorbital pain, myalgia, and arthalgia. And still there is no leukopenia, thrombocytopenia, or plasma leakage. This is mainly a systemic manifestation. There are two very important clues of dengue. One is intense retroorbital pain. Another is extreme degree of pain in muscles, limbs. No wonder the dengue is also been called as a break bone fever. Then coming to the dengue hemorrhagic fever stage 1, here the tourniquet test will be positive and early signs of plasma leakage with platelet less than 1 lakh and hematocrit rise more than 20%. And type 2, here you have frank bleeding has now started with all the points. And type 3, now circulatory failure has started, weak pulse, another thing, and type dengue hemorrhagic fever, dengue shock syndrome, type 4, it is a profound shock and the child has gone almost to the non-returnable stage. So this is a very important test which you can do in places where laboratory support is poor. What you have to do, you have to inflate the blood pressure in between systole and diastole for 5 minutes. And you see after 5 minutes how many petechiae are there in a 1 square inch area. If it is more than 10, then your tourniquet test is positive, but in dengue hemorrhagic fever, you usually have more than 20. So this is the new classification we have now come with dengue. One is dengue without severe sign and one is severe dengue. And dengue, non-severe dengue can be divided into two groups. One is without warning sign and with warning sign. And it is the warning signs which you have to keep in mind, as soon as the child has warning sign, you'd like to admit the child or give better care. Of all the warning signs, gastrointestinal signs are very important. Either you have persistent vomiting or pain. If you palpate, you will find the liver is enlarged and there might be ascites. Besides that, you can have mucosal bleeding, you can have pleural effusion, and you can have laboratory support in the form of falling platelets and rising hematocrit. And if you have a severe dengue, then definitely you are going to not only admit the child, but also put the child at the highest level of medical care. So coming back to our case, we have investigated the case and we found hemoglobin 14 gram%, PCV high 50, WBC count is low 4000 with differential neutrophils 52, lymphocyte 40, and the platelet is low. So if you are asked to give a comment on this, this is a classical dengue hematology. You have initially there is WBC count falls, and thereafter the platelets also falls, and as the capillary leak starts, the hemoglobin rises, so also the hematocrit or PCV also rises. So this is a classical hematological picture in dengue. And if you we send the labs, rapid malaria antigen test was negative, dengue NS1 was positive, and dengue IgM was positive. Does dengue NS1 positive, dengue IgM positive alone suffice to have a confirmed dengue diagnosis? No. You should find out what is the method by which this NS1 or IgM positivity has been done. Is it a non-ELISA method or it is a ELISA method? If it is a non-ELISA method done by immunochromatographic test, then still it is a probable dengue. But if chromatographic ELISA method has been done, and if you see IgM antibody raised by ELISA method, or you can demonstrate NS1 antigen by ELISA method, then it is a confirmed dengue.
Kundu sir, last 5 minutes, please.
So coming to the laboratory confirmation, we have either you go for serology, antigen or antibody, but nucleic acid test, viral cultures we usually don't do. So in the antigen, the most important antigen is NS1 antigen. It starts right from the beginning of the fever and it persists roughly for a week or 9 days. It has a high sensitivity of 96% and specificity of 86%. And if you take the antibodies, they usually rise after, IgM antibodies rise after 3 to 4 days, and thereafter it rises and it continues for about a month. It has a sensitivity of 60 to 90% and specificity. And you remember that any other flavivirus infection, or if you give a Japanese encephalitis vaccine, which is also a flavivirus, then your IgM might be positive. But IgG is a little late to rise. It is after 10 days. But if it is a secondary dengue, then you have a high IgG right at the beginning, followed by low IgM. So what are the other tests you would like to do? You like to do CBC. Or you also like to do electrolytes, kidney function, liver function, do an X-ray chest, see whether there is accumulation of fluid. That's the reason why lateral decubitus, or you can do an USG abdominal test and rule out common things. So these are the admission criteria which I have told you before: persistent high fever, warning signs, neurological abnormalities, sudden drop in temperature, shock, and I'm going to. So two important things I'd like to tell. One is dengue in infants. In infants, dengue is a fairly serious disease and it almost always goes unrecognized. You don't have any signs and other signs and symptoms of dengue because the child doesn't complain. The child might come only with febrile seizures, nothing else. The child might come with vomiting, diarrhea, no skin rash, nothing else. And the child can come with a simple attack of URTI. But what is the problem? The child will go to the shocks of the critical stage very quickly because their reserve is poor. So it is very important during the dengue epidemic, even if an infant comes with non-specific sign, keep dengue in mind. And the most severest form of dengue in infants is usually seen in between the age group of 4 to 9 months. Remember this. And another very important is the neonatal dengue. Neonatal dengue, it usually can be acquired through the placenta, transplacental spread, or during the interpartum period during birth passage. It is during the birth passage which is more important. The neonatal dengue manifestation might vary from very simple mild illness like little bit of fever and petechial rashes to very severe like thrombocytopenia, hepatosplenomegaly, circulatory failure, intracranial hemorrhage. So these things, and the severity of maternal dengue is not associated with or not goes in line in of neonatal dengue. So this is a case which was reported, 2 cases of severe neonatal dengue fever from our hospital. So my last word is mortality from dengue can be reduced to 0 by immediate implementing timely appropriate clinical management, which involves early clinical and laboratory diagnosis, intravenous rehydration, staff training, hospital reorganization. So it is very important to pick up dengue early and treat. And thank you for your patient hearing.
Thank you so much.
Chairpersons can take over.
Yeah. And about the viral hemorrhagic fever, and they are more common in India, like yellow fever, dengue, JE, and K forest fever. And the humans, they are the natural reservoir of these viruses, and they are the multi-system hemorrhagic disease. They are multi-system, like in Invasive, we are seeing in COVID. And these epidemic, they are sporadic and very irregular, and we can't predict when will the outbreak will occur. So we have to be very vigilant, because there is, as such, there is no treatment and cure for established viral infections, and they are for all of the viral infection. And sometimes, so we have to be very vigilant about this, because the early stage, the sign symptoms, they resemble the other, like typhoid fever, other viral conditions, and malaria. So we have to be in guard. And he has very nicely explained about the dengue, which is very common, its classification, its types, and a lab diagnosis, particularly neonatal dengue fever, and we have to, how we have to approach such cases. And there are any question, I think? Yeah.
One thing that I want to mention, that another viral fever, viral hemorrhagic fever, is closely resembling is the chikungunya. Though it's not very much common.
You don't keep chikungunya as a viral hemorrhagic fever, because as such,
but it sometimes resembles symptoms, sometimes resembles the dengue fever.
It can have.
And during the monsoon season, sometimes dengue may present with the other, associated with other co-infections like malaria and typhoid fever. So if the dengue fever is persisting fever, febrile beyond 7 days or 8 days, we need to search for the co-infections. Frequently, we find out the staph typhus, enteric fever, malaria has been associated with dengue fever. I think we need to proceed.
Thank you very much.
Thank you, everybody, and thank you to give me the opportunity to speak in this forum. Okay.
Hello. Yeah, we move on to the next talk by Dr. Kukreja, which is on complicated chickenpox. May I please request Dr. Kukreja to start his talk? His time limit is 20 minutes.
Thank you. And may I share the screen?
Yes, sir. Please.
Can you see?
Yes. We can see the slides. Can you please make it full screen? Yes.
Okay.
Yes, sir.
So, thank you. Good afternoon, dear friends. Now I'll be speaking on the subject of complicated varicella. And varicella is a self-limiting mild disease generally in children. It is usually not complicated. And it's only complicated in rare situations. And when it is complicated, you are likely to see this patient is either immunocompromised or very young infant or adult. And I'll describe few cases which I have seen in my practice in last several years. And then we'll come back to this topic again. So the first case is, this is a female child, 5 years. This girl had chickenpox for 5 days. She was not vaccinated with varicella. She was applying calamine lotion.
and two skin lesions on the left thigh. She had a lot of swelling, redness, and pain. And she was prescribed ibuprofen and paracetamol combination for this. But the pain persisted. And next day, the child was having very severe pain. The swelling had increased. And now the child was having high fever. This for last 12 hours. Now, when the child came to us, the child was febrile, sick looking. It was cellulitis extending from the left upper thigh to up to the knee. And there were something like 3 blisters in the mid thigh area. And the skin was quite dusky around these blisters. And one of the blisters was ruptured also. And there was severe pain. The child was not allowing us to touch even. The child was little drowsy, high fever. She had tachycardia, and blood pressure was slightly on the lower side. And we immediately admitted this patient. Blood samples were drawn for investigations, including culture. And one of the blister, we could take out fluid, which was unruptured blister, for gram stain and culture. Fluid boluses were given. Inotropes had to be given after the fluid boluses because she was not maintaining blood pressure. We started antibiotics, we'll come to that. Immediately we did MRI of the left thigh and we sent the call to the surgeon. And this is a complication of varicella, and that is secondary bacterial infection. Group A Streptococcus and Staph aureus can be the causes. These are the commonest causes. And this secondary bacterial infection can manifest as impetigo, cellulitis, subcutaneous abscesses, associated with lymphadenitis, and sometimes a small blister and a big lymph node. It could be varicella gangrenosa, it could be osteomyelitis, it could be necrotizing fasciitis, and this can lead to toxic shock syndrome, or it could be a bacterial sepsis without toxic shock syndrome. So in this patient, we had a suspicion of necrotizing fasciitis with toxic shock syndrome because everything has happened very rapidly. Or second, it could be osteomyelitis, it could be bacterial sepsis. Let's see what it is. We know how we differentiate this swelling is there on the thigh. Is it necrotizing fasciitis or cellulitis? If there's a very severe pain out of proportion to the findings what you see on the skin, then it is favoring towards necrotizing fasciitis. If it is rapid development of edema, mental state changes, for example, this child is becoming dull, drowsy, there's a marked leukocytosis, and there's an elevated CPK, all these things are very suggestive that I'm dealing with necrotizing fasciitis. Because in necrotizing fasciitis, there's a rapid evolution to myonecrosis. They can lead to cutaneous gangrene, and that can lead to shock and MOTS, multi-organ dysfunction. Now, these are the two bugs which are commonly associated, Streptococcus and Staphylococcus. See what is the difference? Because clinically we have to make a difference. If the focus of infection is soft tissue, it could present as necrotizing fasciitis. If it is pneumonia, if it is following varicella, it is most likely to be there as streptococcal infections, Streptococcus pyogenes or group A Streptococcus. If it is staph, it is usually about the temple use, burns, after surgical procedure, after influenza. So staph is very common after that. If there's a typical rash of sunburn, it is very common with staph. If the positive blood culture is likely to be there in streptococcal, and it's very unlikely to be there in staph because it is basically a toxin after that, and there's no blood bacteremia. Mortality is very high in streptococcus, and it is lower in staph. Now, these were the investigations. Hemoglobin of 10, TLC of 26,800. DLC is polymorphonuclear reaction, shift to the left. CRP is raised. And then you can see by urea, creatinine, and SGOT, SGPT, that there's a definitely multi-organ dysfunction. Even the clotting is disturbed, PT and PTT. And the CPK in this patient was about I think around 1,900 something. I have not, unfortunately, missed out. After stabilization, there was an extensive fasciotomy we had done with debridement of all necrotic tissue. The surgeon had taken the swab after making a cut. They were positive, cocci is in cluster. It was not in cluster, it was in chains. I'm sorry for the mistake because I had to dig out this paper, I think, which I had presented maybe more than 10 years ago, and cultures were sent. Now, it was blood culture, group A streptococcus, wound culture also was group A streptococcus. And what happens is, these bugs, both Staph aureus and Streptococcus pyogenes, both produce bacterial exotoxins which work as super antigens. Now, what are super antigens? Super antigens, they bypass like a traditional antigen and they immediately get attached to T cell receptors. And at a given time in TSS, toxic shock syndrome, up to 20% of body's T cell can be activated straight away. And that's a huge number. And this can lead to a immediate cytokine storm, leading to capillary leak and multi-organ dysfunction. That's the reason it's different from bacterial sepsis. Bacterial sepsis takes some time, and toxic shock syndrome, what happens is, we see something like one patient in 6-7 months, and this patient comes with a history sometimes that the patient was okay, playing in the field, had a minor scratch, and the next day started having pain out of proportion in that area. And the next day the child has come to the emergency room very shocky. So these are normally, these children come with very rapid onset shock. And so our final diagnosis was necrotizing fasciitis, toxic shock syndrome, and with multi-organ dysfunction. Varicella is a well-described risk factor for serious invasive infection caused by group A streptococcus, which can have a fatal outcome. So this was a case where there was a bacterial superinfection following varicella. Now, varicella, in this patient, we gave cloxacillin and clindamycin. Cloxacillin to cover Streptococcus pyogenes and Staphylococcus aureus. And clindamycin is to stop the formation of toxins. And so these two combinations was tried. Luckily, in that era, there was no MRSA. This is an old case. And then next day, we de-escalated to penicillin and clindamycin. And source control is very, very important. I remember this child after 48 hours had to be given IVIG because the response was not adequate. And ultimately, the patient survived. In today's time, if this patient comes to me, I'll be giving something like, because the cloxacillin is not available, so I'll be giving in this today's time vancomycin, maybe with ceftriaxone and clindamycin. And after I come to know if this is Staphylococcus, which is a MRSA, I'll be continuing with vancomycin and clindamycin. And if I find out this is a Streptococcus, I can step down to a narrow spectrum antibiotics, maybe penicillin, even cloxacillin, if it is available. But unfortunately, this is not available. I may continue with this ceftriaxone. And this patient ultimately survived. So this is the first patient. Second case. Now this is a 3-year-old, 6-month-old child, had chickenpox. This child was not vaccinated. And 16 days later, this child developed truncal ataxia. The child used to sit and used to sway on either side. There was a slurred speech, and the child used to walk with a wild bass gait. This was a little unsteady, poor balance, and there used to be lateral veering, means he used to tilt towards one side while walking. He was not able to maintain a straight line. The vitals were normal, there was no nystagmus, there was no meningeal irritation, cranial nerves were intact, and DTR muscle tones were okay. So this patient had chickenpox. 16 days later has developed this type of a presentation. And the symptoms persisted. I kept this child for about, I think he came after 7 or 8 days of this illness. Next 2-3 days I observed, and up to 10 days there was absolutely no improvement. So I did MRI. Normally I won't do MRI because the children tend to improve in 7 to 10 days spontaneously. So I had to do MRI, and MRI was normal. There was no hyperintensities, there was no SOL. So this child, we wanted to start on treatment. IVIG, steroids, and plasmapheresis were three choices. Ultimately, I gave, because the patient could afford, we gave IVIG for 5 days and the child improved. I think the message is the most children improve 90% without any treatment. But this child, because continued to have symptoms even after 10 days, and maybe the child could have improved without treatment, maybe in next 2 weeks or 10 days. But I think parents were very apprehensive, so we gave IVIG in this patient. This is post-infectious cerebellar ataxia. There are several causes of post-infectious cerebral ataxia. Out of that, the most frequent cause is varicella. Acute cerebral ataxia most often develops in children younger than 15 years, and the incidence is something like 1 in 4,000 varicella infections. Other neurological complications, which is dreaded one, is encephalitis, and we treat it like herpes simplex, and this can happen in 1 in 50,000 cases of varicella. Other is aseptic meningitis, which usually is not a big problem, and sometimes they can be acute transverse myelitis. So these are the, after secondary bacterial infection, these are the complications which are affecting the neurological system. Now, case 3. Now, this is a newborn child born to a mother with chickenpox, and the onset was there something like, my screen is being obstructed. Okay. And this was onset was 2 days ago, before the birth of the baby. Before the birth of the baby, it was normal vaginal delivery, uneventful delivery. Weight was 3.2 kg, and the neonate was born to mother with onset of varicella. Rash was there at the time of delivery, and the rash had started 2 days ago before the birth. So we know, all of us, the pediatricians, we know when this between 5 days before delivery and 2 days after delivery, then this is a high risk of severe disseminated fulminant disease. And if it is not managed, 1/3 of the neonates, according to the data, die. So why this is happening? This is happening because there's a high dose of viremia and no maternal antibodies for protection being provided to the baby. So in these cases, we normally tend to give VZIG because it is not available in India. It's a very scarce supply. Then we give IVIG, and sometimes the people have given in combination of both, or sometimes only IVIG, and if the patient cannot afford only IV, acyclovir. But I believe this is a case where I think one should do over and give both and try to save this child. Now, similar problem, infant is born to mother with onset of zoster a day before the delivery. So what will you do in this case? Will you manage similarly or you manage differently? See, such babies have higher level of transplacentally acquired maternal VZV, varicella zoster virus, IgG antibodies. So they are well protected. So in this case, there's no need to treat. Maternal lesions should be covered, and mother should take care of good hand washing when handling the infant. And that's it. Now, there's another problem which I have faced in my practice. The baby is come for adoption and has developed chickenpox. And this is a neonate. Now, there's no maternal history available. And because these babies after birth are abandoned many a times, and there's no maternal history available. So if the neonate develops the chickenpox like rash between 0 to 4 days after the birth, it is going to be a mild disease. If the neonate develops rash between 5 to 10 days of the birth, it is going to be a severe disease. So one has to be careful. I show you the data for that. There's one paper which indicates if there's a rash in the neonate after...
Sir, last 5 minutes, please.
Okay. So if there's a rash in the neonate after delivery, and the day of onset of the rash is 0 to 4 days, there were 22 cases in this paper. There was 0 neonatal death, 0%. And the rash developed 5 to 10 days, within 5 to 10 days, and birth age of the baby is 5 to 10 days. And in this period, the rash comes. So there were 19 cases, 4 neonatal deaths, means something like 20% death. Now, if you go back, So this is a rash which corresponds if the mother had chickenpox 5 days before the delivery. And this one corresponds if the rash is within the 5 days of the birth of the baby. Now, this is the last case. 3-year-old child was being treated with nephrotic syndrome, and 2 milligram per kg was the dose being given of steroids, prednisolone, for almost 26 days. The child developed unvaccinated child, severe hemorrhagic chickenpox lesion. In fact, I had taken few minutes to diagnose. The lesions were quite confluent and all that. And there was a family history of chickenpox in the elder brother, 12-year-old. And this patient was very poor, could not afford treatment, had to be referred to the government hospital. And I wrote the treatment of IV acyclovir and all that and spoke to the doctor there. And we know this type of a chickenpox can be there if the patient is immunocompromised, immunosuppressed, there's a congenital T cell deficiency, malignancy, chemotherapy on the steroids, organ transplant, and these cases are known as progressive varicella. And progressive varicella, there's a continued development of vesicular lesions, there's the appearance of hemorrhagic rash, there can be visceral oral involvement, coagulopathy. This may occur in newborn, immunocompromised, and this is reported in also pregnant women, adolescent, and adults. So if you take the epidemiology, there were 4 million cases in USA before this vaccine era of chickenpox in USA. At that time, their population was 26.6 crores. They used to have these type, about 10,000 to 15,000 hospitalization and 100 to 150 deaths per year. So if I extrapolate this data, which is not a good idea as a temperate zone and we are a tropical country, but somehow it will be something like 50 to 75,000 hospitalization in India and 500 to 750 around deaths. So that's the reason, because of these very small numbers, every death is very, very important. But these numbers, if you take epidemiologically, that's the reason they do not merit for vaccination, unfortunately. So varicella is a serious disease we have learned in young infant, adults, and immunocompromised. Complications are asymptomatic varicella hepatitis, mild thrombocytopenia. In 1 to 2% of children, varicella is there. It may be related to, associated with petechiae, or sometimes GI hemorrhage and hematuria. Secondary bacterial infection, we have spoken. Neurological complication, we have spoken. It can be pneumonia if there is a chickenpox. Pneumonia can happen as a complication of chickenpox, and progressive varicella we have talked. So sometimes other complications which have been reported is nephritis, nephrotic syndrome, renal necrosis, hemolytic uremic syndrome, myocarditis, pericarditis, pancreatitis, orchitis, and arthritis. So prevention of varicella complication, this last slide, in post-vaccine era, vaccination, what has happened in USA? Their varicella incidence has declined by 97%, hospitalization by 93%. Very impressive data regarding effectiveness of varicella vaccine. So prevention of varicella complications is possible. In the utopian world, I'll definitely give varicella vaccine to each and every child, because every child's health is very, very important. I think the limiting factor is the cost of this vaccine. Let's hope in due course of time, the technology comes and the cost can be brought down and varicella complications can be totally avoided in this developing countries as well. Thank you very much.
Thank you so much, sir. Dr. Giri, Dr. Sharma.
Yeah, Dr. Kukreja very wonderfully explained the complication of the chickenpox and all its complications like bacterial infection, encephalitis, ataxia, neonatal, and whatnot. It can go to any system, arthritis, mycobacteria, whatnot. And even it has been mentioned in acute retinal necrosis has been reported with this. So, hello?
Yes,
hello?
sir, we can hear you. We can hear you, sir.
Yeah. Dr. Gore, one thing I want to ask. In those children, some complication has also been reported in healthy, vaccinated children in breakthrough infections, and vis-a-vis those who are unvaccinated. Although in India, the rate of this vaccination is very, very less as compared to Western countries like you have told about the USA. So is there any difference in this? And then regarding the neonatal vaccine, varicella vaccine, if a neonate gets a community acquired varicella infection, not from the mother, so what are the guidelines for using zoster immunoglobulin or acyclovir or IV? If zoster is not specifically available, then IVIG. And one more, that if a baby is born is preterm, less than 28 weeks, and the rash in the mother is present beyond 1 week or 10 days. So are you going to give him this zoster immunoglobulin and acyclovir? So these are my suggestions.
So if it is baby is born before 28 weeks, unfortunately, there's no transfer of maternal antibodies. So that is a big problem. So this was one angle you discussed.
Yes.
Second is if the child is less than 1 year, I'm very keen to give this child protection against a severe disease because I know infants can get a severe disease. So in that situation, I'll try to give acyclovir to all these babies. And if the group is immunocompromised, I'll definitely admit this patient and give IV acyclovir. Any other question which I missed out because there were 2, 3. I covered 2, 3.
Actually, varicella immunoglobulin is not available nowadays.
So you can give IVIG.
You can give IVIG instead of that.
IVIG is sufficient anti-chickenpox antibodies.
Yes, yes.
And because many times what happens, you don't rely maybe there or not. In that situation, many times we have given acyclovir associated with that.
Another thing is that if the immunocompromised patients is developing a varicella, usually it's a disseminated varicella, it is better to admit them in isolation and give IV therapy rather than the oral therapy if the patient is very much.
If it is a disseminated, if it is because if any patient can develop a disseminated varicella, and you find the things are not improving, the child is becoming sick. In that situation, there's a high risk of getting a chickenpox pneumonia as well, and other visceral involvement, coagulopathy. So I'll better admit this patient and give IV.
So can we move on to the next session, please?
Yes.
Thank you.
Because, I request all the participants to kindly post their questions in the chat box, and I request all the experts to kindly post the answers also in the chat box. Due to constraint of time, now we move on to our third lecture by Dr. Chitkara, which is on acquired encephalitis. The time allotted is 20 minutes. Over to you, Dr. Chitkara, sir.
Okay, thank you, and good afternoon, all my colleagues. The topic I am going to discuss is acute encephalitis in children. And I wonder you all would be expecting when I'm discussing encephalitis. I have a surprise for you because all of you must be wanting COVID encephalitis karta hai ya nahi. So I will go into that also. So let's, since it's a very, very wide topic, and to condense it in 20 minutes sometimes becomes very difficult. So I'm only trying to concentrate on the clinical pearls, which would help you in diagnosis and management. Let me start with a case scenario. A 4-year-old boy from Bihar, East UP, marked in red. Fever of 2 days, occasional vomiting, seizures, and altal sensorium. So that triad of fever, seizures, and altal sensorium, you all would say a CNS infection, whether encephalitis, meningitis. But when you see something specifically written Bihar, Eastern UP, what you try and tell us before meningitis is it is an acute encephalitis syndrome. Now, there are many bugs which will cause, especially viruses, which will cause this encephalitis syndrome. And since there are many kind of presentations, there are many other bugs which can mimic or in fact be causes of encephalitis in children. So therefore, we use this term of acute encephalitic syndrome. And there is entire list of viruses as well as, sometimes mimicked by acute pyogenic meningitis. TB can present in any way. rickettsial infection, which is emerging, especially in these northern India regions, cerebral malaria, most common in eastern regions and northeast. Then those are some non-infective conditions like acute demyelinating encephalopathy, mitis, and certain encephalopathies which are always confused. So I think the first learning point from here is that one, encephalitis is a syndrome and epidemiological clues, because as soon as I wrote Bihar and Eastern UP, rather than tell me acute meningitis, you were all thinking of acute encephalitis syndrome, apart from the topic being only. Therefore, friends, encephalitis is largely a clinical diagnosis.
Actually, sir, I think you need to do full screen, sir.
And the three cardinal features are acute onset.
Chitkara, can you make it full screen, please?
Okay, for me it is coming as a full screen here. 1 minute. Is it okay now? Or no?
Not really.
No.
No.
So one of my screens is showing full screen. Let me see if it works again. Is it okay now or no?
No.
No, it's the same screens for us, sir.
1 minute. Since I had duplicated this, I would see if I can. Give me just a moment. But please,
yes, sir, no problem.
मेरा ये टाइम उसमें से निकाल दीजिएगा on your timer.
yes, sir.
So this is coming on only 2. So is it okay now? Is this okay?
This is perfect. Good.
Yes, sir, we can see now.
So therefore, remember, encephalitis is, it's changed again.
Yeah, the font is too much. Okay, well, perfect, sir.
1 minute, please, 1 minute. Okay. Okay.
Yes, sir.
Okay. So 3 are tried: short febrile illness, altered sensorium with seizures, focal neurological signs. CSF may not be of much help, but abnormalities in neuroimaging is important with a non-specific EEG. And remember the last line: you have to rule out an alternative diagnosis before you label it as an acute encephalitis in children. So therefore, with this kind of a presentation, when you think of encephalitis, which is caused by a list of bugs, starting most commonly from the viruses to some bacteria, plus now increasingly other organisms like rickettsia, which are being easily recognized. Let's see what's been happening in India. See, in India, we always said encephalitis, most of us would believe it is Japanese encephalitis. But if I show you the data of last almost about 8 years, the acute encephalitis remains the same, almost the same, because for majority of India, it is sporadic. There are certain districts which are endemic. The proportion of Japanese encephalitis after our Japanese encephalitis vaccine program, which has been given, that has decreased if I compare it with all cases of encephalitis. But acute encephalitis over the years has remained the same. However, what is noteworthy is that with a proper access to medical care and probably awareness, the mortality and the case fatality has increased. So when JE has increased and the numbers have remained same, so what are the new bugs which have arrived on the scene? And they are the scrub typhus, Japanese encephalitis remains endemic, enteroviruses, ecovirus, And the recently talked, right, Ritabrata Kundu was talking on dengue, chikungunya, herpes, the new kid on the block, which has been Nipah just about 2 years back in Kerala, and the West Nile virus. So these are the bugs now where proportions are increasing. So therefore our encephalitis remains the same, the overall numbers, but the proportion of bugs that cause encephalitis has changed. So then what are the clinical pearls? See, damage can be either because of an infection per se, viremia, or an immune mediated insult. It is invariably a life-threatening event. So therefore the early diagnosis, which is often presumptive and probable, is important. Laboratories sometimes really do not help because CSF has a very typical kind of a normal or near normal kind of a picture. The neuroimaging, which is very important, gives you a clue in about 60 to 70% of the cases. Again, sometimes remains non-specific. ECG is again non-specific. So what becomes most important second point is epidemiological clue. Like that is why I wrote those Bihar oblique Eastern UP, because then you know the patient coming with a neurological illness of a short duration is from a district where encephalitis is endemic. Now, extracranial physical signs become very important if you have to pick up the etiology of encephalitis other than various viral encephalitis. The treatment is generic. It is always advised that you hit hard and broad because there are so many pathogens. But as evidence emerges, you must de-escalate the treatment, and I'll come to that. So now let's validate the clinical pearls which I have told you in the last slide. I think the most important for us in India, in a tropical country, is that summer is a time when we have more encephalitis. If you go by the history of encephalitis in this country, it is invariably during the summer times because we have lot of vectors, lot of issues with paddy growth and farmland cattle. So therefore in summers, these enteroviruses, arboviruses or the flaviviruses, rickettsia, because people move out mostly in the summers. So that is a time when you have peaks of encephalitis, whatever district you may say. Another important point in diagnosis is a clustering. If you have a clustering in a selected geographical region, sometimes it appears that it is more of an encephalopathy rather than an encephalitis. And a typical example is of that chamki in Bihar caused by lychee, unripe lychee. And a few years back, our colleague Vipin had reported from Saharanpur because of a roadside weed which was accidentally consumed by children. That was Cassia occidentalis. So clinical clues, therefore the overall clinical examination of the patient would give you very important information as far as the etiology is concerned. Rita Brata did talk about rash with fevers, tropical fevers. I am talking of rash with encephalitis. So if you have vesicular lesions, think of herpes simplex, varicella zoster or other herpes HHV6. However, if you have erythematous rash, then rubella, measles, they come into picture. Mycoplasma has multi kind of a poly type of a rash, but rarely vesicles appear, though you may have something like a vesiculitis. Neurological findings, when you find that the patient has more of extrapyramidal symptoms in the form of dystonias, extrapyramidal rigidity, our friend Japanese encephalitis, which has been endemic for so many years, is the major culprit. However, if the patient has flaccidity, polio which is gone, but JE can cause this, and enteroviruses, non-polio enteroviruses can also cause encephalitis with the flaccid paralysis. One thing which is very dangerous is a brainstem encephalitis caused by enterovirus and herpes virus, which has got a very high mortality because of all the important kind of a vascular support or a respiratory support. So then how do you investigate these patients? Investigations are threefold. One, you assess what is the organ damage which is associated along with an encephalitis. You try and confirm the diagnosis of encephalitis and also find a clue to the etiology. Not that etiology matters much, but that you have a specific cure for 3 to 4 bugs which can cause encephalitis. So investigations become important. Apart from the routine assessment of a patient, what you do, the serologies become very important. These are now increasingly being available in India, and serology for enteroviruses, EB virus, HIV, mycoplasma. So these come in very handy. However, this receptor, that methyl deaminase, it's a big name, anti-NMDAR, which we say, and the voltage gated potassium channel antibodies are increasingly becoming important, especially in a child who's adolescent and has got acute encephalitis. So it is always wise to keep an acute serum handy so that as and when the clinical clues develop, you can send it for a retesting. Now, CSF, you all know, in a viral encephalitis would either have a mild cellular response with just normal or low sugars, especially in mumps encephalitis. Otherwise, you may have it normal or a mild protein elevation. This is in contrast to what you see in a pyogenic meningitis and more so in tubercular meningitis. So again, CSF is a very important body fluid where a lot of multiplex PCR assays are available, those biofires, which can detect almost 14 neuropathogens and give you to the clue of diagnosis. Sometimes the etiological clue may not be important as far as the treatment is concerned, except for rickettsia or Japanese encephalitis, or for a fungal infection or a bacterial infection. But these are more important for an epidemiological finding, especially when you have lot of patients or an outbreak which is there in a defined population. Again, keep a CSF sample handy for subsequent testing as and when the clues emerge. Now, neuroimaging, I said, would give you something suggestive of an encephalitis in 60 to 70%. It may be just cerebral edema or inflammatory lesions like of cerebral cortex, what we call as cerebritis, loss of gray white matter junction, or localization to thalamus and basal ganglia. Sometimes meningeal enhancement along with meningoencephalitis, or more important, if you have a temporal localization and hemorrhagic encephalitis, HSV is the probably culprit and is a treatable disease. Now, MRI is definitely more sensitive, but it is prolonged, it takes more time and is expensive. Though CECT is a very cheaper option, easily available these days, and invariably neuroimaging is very important before a lumbar puncture, especially in older children, to rule out any mass lesions or midline shifts. One entity which always confuses with encephalitis is a demyelinating encephalomyelitis, which is invariably post-infectious or post-vaccinations. And this is a typical disease. I would not go into details into it. However, neuroimaging also comes in very handy when an encephalitic-like presentation is by a head trauma or a CNS trauma, a tumor, or you want to see some intracranial calcifications. EEG really doesn't help apart from being a low voltage generalized pattern, except if there is a temporal localization, it gives you a clue towards HSV. So these are some of the images: temporal involvement, HSV, hemorrhagic involvement, HSV, the brainstem kind of an involvement where you see these hypodensities in the pons, rhomboencephalitis, JE typically characterized by bilaterally symmetrical involving the basal ganglia, and this demyelinating encephalomyelitis, which has got subcortical hyperintensities, which are most in the kind of periventricular lesion. So these are the some typical pictures of an encephalitis. How do you manage? Apart from a supportive system, seizures should be controlled, manage intracranial pressure, and empiric antimicrobial therapy, when I said always hit hard. Why? HSV treatable. So acyclovir is your part of the routine. Antibiotics, because I cannot rule out meningitis initially. So I put them on our community protocol of treatment of pyogenic meningitis. Those areas where, especially mycoplasma or rickettsia is an important etiology of encephalitis. Now, in the last few years, it was there in eastern UP as well as in Himachal Pradesh. So azithromycin is a part of the spectrum. So you hit hard, hit broad, and then gradually as you collect evidence.
Sir, last 5 minutes, please.
Okay. Acyclovir, please remember, younger the child, higher is the dose, about 15 to 20 milligram per kg 8 hourly. But in an older child and adolescent, it is 10 milligram 8 hourly, given for 21 days. If you prove HSV to be the culprit, must treat for 21 days. If you have evidence by 4 to 5 days in PCR or a serology that it is not HSV, or there's no temporal localization, maybe you can stop early. Emerging pathology is an autoimmune encephalitis. I told you any adolescent with an acute encephalitis-like presentation, with the neuropsychiatric symptoms, please think of autoimmune, and therefore the sample you kept for a serology must be sent for NMDR and a VGKC antibodies, because this is being now increasingly recognized, and in some countries it is almost 13% of the total encephalitis. Importance is that these NMDAR encephalitis is sometimes associated with tumors, so you have to be on a lookout for these tumors. So as I said, nothing these days is complete without COVID causing, because everything can be dumped onto the COVID these days. So very interesting observation these days. So there have been numerous neurological involvements related to COVID, including acute encephalitis. So you need to have a careful clinical and a diagnostic as well as an epidemiological approach. That is the importance, because you cannot any neurological sign just putting it, piggybacking on a COVID just because the RT-PCR is positive or there is an evidence of COVID antibody. You need to have a precise case definitions, which either it is caused directly during viremic phase. This is what is COVID related. But hypoxic encephalopathy and a critical care encephalopathy in a multi-organ failure in a patient of COVID is actually not COVID encephalitis. So high strokes because of hypercoagulable state is not an encephalitis. Guillain-Barré syndrome is not an encephalitis. So therefore case definitions become very important. And there should be evidence of either in the form of RT-PCR positive in CSF or brain tissue, or CSF positivity of antibody, rather than just a plasma positivity of antibody plus no other alternative pathogen found.
So last 2 minutes.
Yeah, so these are the various neurological involvements reported with COVID in the last 1.5 years. And some of the CT and MRI pictures in COVID, which varies from hyperintensities to mesial sclerosis to ischemic lesion infarcts, so to kind of cerebritis. So these are mesial changes are suggestive of an encephalitis. And finally, we ourselves reported one neurological involvement in a COVID-19 patient, which was ADEM, and the patient recovered. Thank you, friends.
Thank you so much, sir. Over Dr. Giri and Dr. Sharma.
Yeah, Dr. Chitkara has very wonderfully and nicely explained all these conditions, and he has stressed that when the patient come in early stage, and there are lot of things come to our mind, whether this is a partially treated meningitis, or this is viral encephalitis, or some poison, or some other thing. And so one has to, first we have to stabilize the patient, examination, and then some test. He stressed that one should give a cocktail therapy. We cannot wait for the report of this herpes simplex or PCR or CS of things. So one has to give as antibiotic ceftriaxone, one has to give acyclovir, and one has to give start with a polytherapy or a cocktail therapy. Then Chitkara, there is any role of minocycline in azithromycin in this Japanese encephalitis? Jay?
Minocycline.
Mino.
Minocycline is a tetracycline kind of a derivative which is not there. JE, there is no specific treatment.
It was tried in this JE also. In yesterday there was one webinar, and they discussed that minocycline and azithromycin.
Azithromycin has been primarily given for rickettsial.
Yeah, right.
But not minocycline. Minocycline, one may try doxycycline, but I am sure the doxycycline really doesn't cross blood-brain barriers. And plus, even in rickettsia, now use of azithromycin is a little dicey because we feel it is more of an immune-mediated neurological damage rather than because of either a mycoplasma or a kind of a rickettsial parasitic damage. So therefore, it is only to eradicate the parasite so that those antibodies are not formed. Azithromycin is in protocol for our eastern UP and some cases of encephalitis in Himachal. Minocycline, I am not aware, Dr. Satish.
Yes, sir. And I think this is a very dreaded disease, very fastly, rapidly progressing. So we have to consider about preventive strategies like surveillance, vaccination, and vector control. And also a part of the, management of this. And secondly, those who survive, then their survived patient, their rehabilitation in addition to this. Thank you very much, Dr.
Yeah, there is a question in chat box on role of steroids. Steroids are only indicated when you have raised intracranial pressure, dexamethasone, and also if you have tuberculosis as a kind of a presentation with an encephalitic presentation. So there the role of steroids are there, but in other viral encephalitis, especially with a viremic damage, we say steroids will not have role except for ICP. You have other decongestive measures before you use steroids.
Thank you. I think we can end this session now and move on to the next session. Thank you all our experts and our chairpersons.
Thank you all the learned three speakers, and they spoke very well and newer insight in, and we have learned a lot of things, and these are practical importance in our day-to-day practice. I convey my thanks Central IAP and ID chapter and to arrange this midterm CME and give you the opportunity. Thank you.
Thank you.
Thank you, Dr. Sharma. I now request Dr. Sushruta to take over and kindly conduct the CME further with the next sessions.
Thank you, Dr. Manisha, for taking us through till here. And I will be navigating the further sessions. So moving ahead, we have the next session coming up is a panel discussion on abdominal infections. The practice pulse. Abdominal infections which we routinely see in our OPD practice, we don't know when to investigate, what to investigate, do we need to treat. So we have this eminent panelists here who will guide us through that. For this, the moderators for today's session are Dr. Yagnesh Popat and Dr. Atul Kulkarni. The panelists are Dr. Mahesh Kore, Dr. Chetan Trivedi, and Dr. Surendranath M. I need to, yes, I need to share screen. So somebody who shared this thing, can you please stop sharing? Yes. Just give me a moment. Yes, so Dr. Yagnesh Bhukat is a consultant pediatrician at Rajkot, chairperson of ID chapter of IAP 2021. His areas of interest are vaccinology, infectious diseases, and nutrition. He is fellow IAP of 2014 and chairperson of IAP Infectious Disease chapter 2021. Dr. Atul Kulkarni is a consultant pediatrician and is in charge of NICU Ashwini Hospital, Solapur, and is an assistant professor at Ashwini Medical College, Solapur. He has been a faculty in various state, national, and international conferences, and he has multiple publications in various journals and IAP books and IAP atlas to his credit. Dr. Mahesh Kore is a pediatric and neonatal intensivist at Shri Hospital, Belgaum. His areas of interest are rheumatology and inborn errors of metabolism, and he has had multiple articles to his credit. Dr. Chetan G. Trivedi is a practicing pediatrician and neonatologist in Ahmedabad. Areas of interest are vaccinology, infectious diseases, respiratory medicine, and general pediatrics. He is a joint secretary of IAP ID chapter 2021. He is contributed as an author for chapters in various books and review articles in ID journals. Dr. M. Surendranath, he is HOD Department of Pediatrics, Vijay Mari Hospital, Hyderabad, President of Academy of Pediatrics, Telangana State, and he has done a fellowship in allergy and clinical immunology. He has been the Vice President of Central IAP 2019, and at present he is the Vice President of the ID chapter for 2021. Yes, so we move ahead to the moderators, Dr. Yagnesh Popat and Dr. Atul Kulkarni, to carry on the further proceedings. Thank you.
Good afternoon, friends. Thank you, Dr. Sushruta, for a nice introduction of our friends. In next few minutes, we'll be discussing the various aspects of intra-abdominal infections which are encountered in our day-to-day like this. Abdominal pain is one of the most common reasons to seek assistance in the emergency room. Reasons of abdominal pain are numerous, ranging from most benign to the serious life-threatening infection. Causes may vary as per the child's age, nutritional status, or the immunological status of the child. So it is often labeled as Pandora's box, from which many a time you get a surprise reward. To discuss various aspects, I have my colleague, Dr. Atul Kulkarni as co-moderator, Dr. Mahesh Kore, Dr. Chetan Trivedi, and Dr. Surendranath as a panelist from the various parts of the India. So with the help of them, let us start our journey. I request Dr. Atul to start the presentation. Dr. Atul, please.
Yeah. So intra-abdominal infection, abdomen cavity is a sterile cavity which consists of a peritoneal cavity and retroperitoneal cavity, and there are various structures like gastrointestinal tract extending from the esophagus up to the stomach up to the colon, liver, gallbladder, and spleen. If you see this intra-abdominal or intraperitoneal space, it is divided into supracolic compartment, infracolic compartment, and pelvic compartment. And basically, it is a peritoneal and retroperitoneal space. There are potential some spaces like a perihepatic space or subdiaphragmatic space or infradiaphragmatic space or perinephric space, where sometimes the infection can occur and it becomes very difficult to find out this infection. But with the newer modalities of imaging, we can diagnose this infection if suspected with a fever, presenting with a pain in abdomen, or fever without focus. In this sterile compartment, there is gut in which there are millions of microorganisms. And this gut microflora, which changes from stomach to the colon. In stomach, there is a gastric acid, and usually the microflora are helicobacter, streptococci, lactobacillus. In upper intestine, gram positive and gram negative, and some anaerobes. As we go down in the ileum or distal part, we get a majority of gram negative organs like E. coli, Klebsiella, few gram positive, and anaerobes. And in the colon, most of the anaerobes, gram negative organisms, and staphylococci and enterococci are usually seen. And if these organisms come into this sterile compartment of peritoneum, it can cause a severe intra-abdominal infection. So let us, and this intra-abdominal infection results in the two major clinical manifestations. Early or diffuse infection, which results in the localized or generalized peritonitis, or late and localized infection producing intra-abdominal abscess. So let us start with the case. 3-year male child, known case of nephrotic syndrome, on alternate day steroid regime. He has presented with a fever for last 4 days, irritability, vomiting, loose motions, and abdominal pain. So anyone, Dr. Mahesh, what do you think? What this child is going on?
This child is of nephrotic syndrome and now was on alternate day therapy, but he has a fever, irritability, vomiting, loose motions, and abdominal pain. This can be simple because of acute gastroenteritis. And I want to know about his condition, whether he's a sick looking child, whether the abdominal pain is very severe, how are the loose motions. And we can divide this into two: a simple gastroenteritis, which requires a supportive therapy, and a serious one because he is on alternate day therapy, but he has maybe just completed the 6 weeks of daily therapy. That's why we may consider him as an immunocompromised child within 15 days of completion of 2 milligram per kg per day therapy. So we want to know whether he is sick looking or not sick looking. That's my first question.
Suppose the fever is not there and child just has come with the severe abdominal pain of a nephrotic syndrome and vomiting. What are the things comes to your mind?
Yeah, there are two complications in a nephrotic syndrome. One is a vascular one and one is an infective one. So infective one is in abdominal pain, which is severe without fear also, which is called spontaneous bacterial peritonitis. And second is a vascular renal vein thrombosis.
Okay, that's absolutely right, because child is on steroids, so sometimes fever may not be there even in presence of infection. So fever may not be the major criteria. You have to go for the clinical presentation and clinical examination. So let us go. How was the child? This was the child. Child was very toxic, irritable. There was tachycardia, tachypnea. Blood pressure was 90/60. Periorbital edema and pedal edema was there. There was a tachycardia. Child was tachypnic. Abdominal distension was there. And there was a tenderness, free fluid was present, and reduced peristaltic sounds were there.
Yeah, now we are dealing with the serious illness.
So what you are thinking?
So I should answer?
Yeah. Yes, Chetan, you can.
Yeah.
Good afternoon, everyone. Yeah, this patient, as we know that it belongs to nephrotic syndrome on steroid. And nephrotic syndrome, one or very peculiarities, they were having a hypoalbuminemia as well as proteinuria. So they also make them more, liable for some infections. So whenever this patient is there, we will be always watchful for this kind of complication which we expect, because there is peritonitis which is most dreaded and most expected complication when the patient of nephrotic syndrome is on steroids. So yes, this patient is toxic. What Dr. Kore wanted to say that it's just an acute gastroenteritis. It is not there, because this is a toxic looking child, irritable, tachycardia, tachypnea, even edema is there just maybe because of nephrotic syndrome only. But simultaneously, there's a distended abdomen and tenderness. Also, you can feel that it's a free fluid is present. That is maybe clinically it has been observed, and reduced peristaltic sound. See, everything it points towards the intra-abdominal issue. And so there is definitely, we are suspecting a peritonitis, spontaneous bacterial peritonitis, because a case of nephrotic syndrome, going for this kind of symptomatology, then bacterial peritonitis is the most likely. So yes, we would be keeping that in mind and would like to prove our diagnosis with investigations. Maybe we'll go for the basic investigation, maybe in form of CBC, electrolytes. Also, we would like to go for CRP, and we would like to go for in like sonography, USG abdomen. So just we would try to reach to the diagnosis with these kind of investigations.
Okay. So let us see what investigation revealed. CBC was showing hemoglobin 12 gram, total count 14,200 with a polymer of 70%. Platelet count was normal, electrolytes were normal, CRP was raised, it was 240. USG abdomen was showing mild hepatomegalia and ascites, and urine was showing albumin 3+ with PC ratio of 8. So with this, what you are thinking? And your blood culture was also sent at this time.
Yeah,
So here-
definitely now. Yeah,
please.
definitely now CBC has shown polymorphonuclear leukocytosis with CRP so high. So our clinical diagnosis of spontaneous bacterial peritonitis holds true in this case. And because of infection, he has again relapse of nephrotic syndrome because albumin is 3+ and protein to creatinine ratio is more than 2.
Yeah. So there is a relapse because of infection, and some infection is there in the intra-abdominal cavity. So how to confirm the spontaneous bacterial peritonitis?
We like to do a peritoneal tap actually to prove that it is a bacterial peritonitis, and we have to send it for culture as well as for microbiology or cytology.
Right. So ascitic fluid examination was done. It was showing 380 cells, 75% neutrophils, protein 4.3 gram, and culture was also sent. Gram staining didn't show any. There were few pus cells, but no organisms were seen on the gram staining. So what is this spontaneous bacterial peritonitis? SBP.
Spontaneous bacterial peritonitis, we have different type of peritonitis. We have a spontaneous bacterial peritonitis. That means the infection has come not from within the cavity, it is come from outside. So whether it is a hematogenous route or lymphatic route or some other route. So spontaneous bacterial peritonitis, or it is called primary bacterial peritonitis, it is an infection which is we are having in a peritoneal cavity without there is in any intra-abdominal source. And this is usually been found in patients of particularly nephrotic syndrome and cirrhosis. These two are the most common conditions where we find this primary bacterial peritonitis or spontaneous bacterial peritonitis. Because we know that the reason behind this is either there is an immune dysregulation or there is a translocation of gut bacteria. So this is the way we get the primary peritonitis or a spontaneous bacterial peritonitis. So we can have a secondary peritonitis, bacterial peritonitis. That is like you get the infection from the organ. Yes, please.
Yeah, Chetan. So what are the other risk factors for this spontaneous bacterial peritonitis? Let us finish spontaneous peritonitis first.
Okay.
Yeah.
See, particularly if the patient has already had that previous history of spontaneous bacterial peritonitis,
yeah,
that is also one of the very important cause for that. And as you said, that cirrhosis, and if there is a serum bilirubin which is more than 2.5, or there is a hypoalbuminemia and ascitic fluid protein is also less, or there is a malnutrition. These are the other risk factors which you might find bacterial peritonitis. Particularly, it is just immune dysregulation and the translocation of the bacteria.
And also serum cholesterol more than 400 in a nephrotic child is an isolated risk factor for spontaneous bacterial peritonitis. From a JIPMER, a paper from JIPMER has said that serum cholesterol more than 400 mg/% is an isolated risk factor.
Okay.
So that should be considered.
Yeah. And also use of proton pump, excess use of proton pumping is one of the, what are the common microorganisms which are implicated in this?
Shall I?
Yeah.
Yeah. Most common organism, particularly when we are looking at the nephrotic syndrome, there is only one organism we should remember, that is the pneumococci. And that's the most common organism we find in nephrotic syndrome. Yes, there can be other like organisms like group A streptococci, enterococci, or staphylococci, and also the gram-negative. Very rarely we might find mycobacterium tuberculosis or bovis or meningitis, but most common is pneumococci, and that will, I think, even antibiotics covering that organism will be sufficient when we are talking about the nephrotic syndrome, spontaneous bacterial peritonitis following nephrotic syndrome.
Yeah. So how will you evaluate? Already we have discussed that CBC may show polymorphonuclear leukocytosis. X-ray abdomen may not be very much useful, but dilated large small intestine, increased separation of bowel loops may be seen, and diagnosis by the paracentesis cells more than 250, more than 50% of neutrophils, and usually this peritonitis, as you said, is a monomicrobial. So you get a single organism. So let us come to what is secondary peritonitis.
Even Atul,
yeah,
in the recent guidelines of steroid sensitive nephrotic syndrome, they have said even more than 100 cells
100
per
also, yeah.
cubic mm. We should
Absolutely
consider
right.
it the bacterial peritonitis. That is the latest which has been released few days back.
Right.
The guidelines for steroid sensitive nephrotic syndrome. So even we should not wait for 250 cells. So that is a very strong suspicion we should have of
Clinical
a
suspicion.
peritonitis, that
Clinical
even if there's that much doubt, we should go for antibiotics and we treat it very vigorously and seriously.
Yeah. So what is the secondary peritonitis?
Yeah. Here, like, yes, Surendra sir. Is there?
Yeah.
Yes, Surendra sir. You are correct.
As we have discussed in a nephrotic syndrome, normally any patient presenting with pain, abdomen, fever, even without any other signs also we should suspect primary peritonitis, definitely. So secondary peritonitis is mostly because of the infection which is occurring in the lumen of the intestines. So most commonly what we see in a newborn, sometimes NEC, necrotizing enterocolitis, or meconium spontaneous perforation also can occur. Sometimes in the older children, perforated appendix is the most commonest cause of secondary peritonitis. And whenever there is rupture of any intestine is there is likely secondary peritonitis. Not only that, sometimes some trauma can cause secondary peritonitis. The other things are inflammatory bowel syndromes. These things also can cause secondary peritonitis. Secondary peritonitis is the organisms which are coming from the bowel or organisms which are entering from the outside. It is not a hematogenous spread. Most likely that a local infection which is occurring because of the rupture of the intestines or perforation of the peritoneum because of the external factors. These are the causes of secondary peritonitis. So most commonly seen in surgical emergencies.
Okay. Okay, that's fine. So just to summarize, how to differentiate primary to secondary peritonitis. It is a no intra-abdominal pathology in primary. Secondary intra-abdominal pathology is there. Monomicrobial, this is polymicrobial. No gas under diaphragm. You may get a gas under diaphragm in secondary peritonitis, and no surgical intervention usually required in primary peritonitis, but surgical intervention will be required in the secondary peritonitis. So this child was started on the ceftriaxone, and metronidazole was also added, and culture report came sterile. So what are the recommendations as antimicrobials in case of suppose the culture is sterile, or empirically what antimicrobials you are going to start with peritonitis or interabdominal infection?
As I said that this patient is of nephrotic syndrome, and where the organism we suspect is most common is pneumococci. So in pneumococci, at the most we might have few anaerobes. So to cover both of them, I think we can start with ceftriaxone, and yes, metrogyl you can start. But I think I would like to go for only ceftriaxone. That will be also sufficient. Only in case when we are having some resistant pattern of ceftriaxone, we might have to go for vancomycin. Otherwise, ceftriaxone is more than enough for all the cases of nephrotic syndrome going for bacterial peritonitis.
Absolutely right.
One thing, if the patient is very sick, toxic,
okay,
and sometimes ceftriaxone may not be enough when the child is very toxic. And what I'm telling is, sometimes you may find other culture is sterile in this patient. No? May not be sometimes pneumococcus. Pneumococcus is very difficult to culture also. But when it's very sick child, definitely maybe sometimes we may have to go to the higher antibiotic.
Yes. So as the Chetan was saying, this was a case of nephrotic syndrome, probably SBP, spontaneous bacterial peritonitis. One can start with the ceftriaxone, and depending upon the clinical condition, as Dr. Surendra said, suppose the patient is having secondary peritonitis, not this case, but secondary peritonitis, having a patient is very sick, we may have to go for higher antibiotics. What are the recommendations for intra-abdominal infection? Which antibiotics you can start with?
So most commonly is definitely third generation cephalosporins is metronidazole we start with.
Yeah.
Depending on, as you told, that if the patient is very bad, maybe we can go to piperacillin tazobactam also.
Yes. Yes. Dr. Mahesh, you want to add something?
Yeah, no, this is very simple organism actually, because in pneumonia, streptococcus pneumoniae in meningitis is different than the intra-abdominal infection and the lung infection. So resistant to the third generation or first generation also is not there. So we can stick to ceftriaxone, and maybe because it is gut, we may add metrozole, but it is always not needed.
Yeah. So
if
vancomycin is also not needed.
Not needed. So, but in secondary, I am asking for the sex. Suppose this is not a nephrotic syndrome.
Yeah.
You are just discussing. Suppose secondary bacterial peritonitis is there. The child is very sick. Are you going to start with the ceftriaxone only?
No. If it is a secondary, then we can add, like we can start with piperacillin, tazobactam, and metronidazole, because it will require that in higher generations or resistant organism therapy.
Because it is a polymicrobial infection.
Yeah.
So it won't be the only monomicrobial. So we need to cover all the gram-negative, gram-positive, anaerobes, as well as the most likely pathogens. So we have to have broad coverage, and that's why we will start with BL-BLI, allowing it metrozole, or we might have to go for aminoglycosides also.
Here, but if you are using piperacillin tazobactam, it has a very good anaerobic coverage also. So you do not need to add a metrozole, metronidazole, or even with the meropenem, which is having a very good gram-positive, gram-negative, and anaerobic coverage. So we'll just see what are the guidelines. Sir, Dr. Surendra, sir, what vaccination you will advise for the nephrotic syndrome, and when this child would be vaccinated, and which vaccination you will advise for the patients with nephrotic syndrome? Yeah.
Nephrotic syndrome children are immunocompromised children. So definitely we have to advise most important vaccines should be completed before starting steroids are pneumococcal conjugate vaccine and varicella vaccine. These two should be given before starting the steroids. Definitely. And all those contact people also sometimes, because immunocompromised individual family members also should also be vaccinated against the varicella. So these vaccinations ideally should be given before starting steroids, but because these are all inactivated vaccines except varicella, varicella cannot be given once you start the steroids. You have to stop the steroids, then only you should give the varicella vaccine after 1 month.
How much gap after stopping the steroids?
1 month.
1 month, 1 month. If the child is on continuous steroids, depending on the weight, because the 2 milligram per kg body weight, if the child is about 10 kg, if the more than 20 milligrams per kg for more than 2 weeks, then we have to stop the steroids, wait for 1 month and give the live vaccines like varicella and MMR. So varicella can be completed if the child can wait for the steroids. Sometimes when you diagnose a nephrotic syndrome, you don't start immediately steroids. Sometimes spontaneous remissions also do occur. So you can wait for some time, I think. Maybe at that point, you can give the pneumococcal conjugate vaccine and varicella vaccine and finish and then start steroids. Unless the child is very badly having NSRK. In that case, maybe you can give pneumococcal conjugate vaccine even during the steroid period also, but seroconversion rates will not be so good compared to the normal child. So you have to do a antibody test and then repeat the pneumococcal conjugate vaccine. Yes.
So ideally, in nephrotic syndrome, we should be very particular about pneumococcal vaccine, because we know that pneumococci is going to be a very important organism. So, and nephrotic syndrome, once you diagnose, we are not sure. Sometimes it might be, that it might respond to steroid properly, or you might require to go for a prolonged steroid. So as early as possible, you get a chance that the patient is in remission and the steroid has been stopped for 1 month. You should take an opportunity to vaccinate as many as vaccination possible. Because sometimes you might not get time or chance to vaccinate properly because we are on steroid for the prolonged period of time. Because first time diagnosis, we are not sure that it will be a steroid response and it will be behaving very smoothly.
So all the capsulated organism vaccination should be done in the nephrotic syndrome. So I'm just going through the initial management of suspected confirmed intra-abdominal infection, which is a severe infection. One should go for routine history, physical examination, abdominal imaging. The most important is initial assessment and rapid restoration of intravascular volume as per the sepsis guidelines. And starting of antibiotics as early as possible is very important if child is in the shock or in a very sick, child is very sick. So fluid resuscitation and antibiotics should be started immediately. And another important thing is source control, which is very important. This source control is the single or multiple series procedures in which it eliminates the infectious focus, controls the factor that promote ongoing infection, or correct or control the anatomical derangement to restore the normal physiological function. So when to do this source control? If it is a diffuse peritonitis, immediately once the child is stabilized, hemodynamically stabilized, one should go for the source control. And if child is hemodynamically already stabilized without peritonitis, then we can delay with the 1 day is acceptable. So source control, how we can do is imaging, ultrasound guided drainage of abscess, or if required minimal invasive surgeries, or sometimes if there is a perforation or things, we may require laparotomy. So the surviving sepsis guidelines and other guidelines endorse that early adequate source control in the intra-abdominal infection is very important. Many times what happens, child is very sick, there is perforation, there is peritonitis, we have revived, the platelet count is very low, surgeons are reluctant to open the child. But please make it that the surgeon give him confidence, give platelet transfusion, make child stabilize, and ask him to open whatever is required. Source control is to be done as early as possible. Otherwise, the mortality in these cases will increase by 3 to 5 folds. So this source control is very important. So these are the recommendations for the antibiotic therapy. If you are using a single agent, you can use in sick patient, sick and toxic patient, you can use a carbapenems or tricarcillin cavelinate or piperacillin tazobactam. If you are using combination, so third generation cephalosporin with metronidazole, gentamicin and tepromycin, they are now not recommended. With metronidazole or clindamycin without ampicillin, this can be started. So the best is the sick patient, you can start with the piperacillin tazobactam or carbapenem depending upon the child's serious sickness, and or you can start with the third generation cephalosporin with metronidazole. These are the various pediatric doses of antibiotics: third generation cephalosporin, carbapenem, metronidazole, and vancomycin. Whenever if you get a MRSA, you can use a vancomycin. So we finish with this case of first case. I request Dr. Yagnesh sir to start with the second case.
Yeah, friends, now we have another case of 10-year-old female who presented with fever, vomiting 3 to 4 episodes, abdominal pain, which is dull in nature and with intermittent exacerbation since 1 day. The stool not passed today, it was passed yesterday. What is your thought process? What it could be? It could be a serious
need more
infection.
information on this, sir, because
yeah, it could be a simple infection or it could be a serious infection. We do not know right now.
Yeah, right now we don't know because only 1 day of fever, vomiting, abdominal pain can be anything.
So it could be just a simple fever with simple gastritis because of any reason.
Yeah.
Yes.
Maybe how was the abdominal pain? We want to know about abdominal pain, whether it is
it was initially dull aching, and that thereafter with intermittent exacerbation since
and
1 day.
Child was not able to sleep at night.
Yeah, now we come to it. Next slide, Atul.
I think this is simple high-grade fever, vomiting, abdominal pain. So any viral infection can present like that.
It could be a simple infection or it could be just a
But point against is one is abdominal pain, which is dull with intermittent exacerbation. So that is very specific. It has been mentioned. It is not that just mentioned. It's just a pain in abdomen. And stool not passed. Usually we don't follow that rigidly that stool has been passed today or not. But many times
that was parents, not gastroenteritis. That is what it was.
Yes, but parents, they complain from they have not passed the stool. So they will hint that it may be a constipation which has been there for 1 day, and that's why patient is having this abdominal pain and vomiting. So patient might drag us to a different level.
But it is associated with fever, so probably it is not a constipation. Yes. Next slide. Yes. So after a few hours, as Dr. Kore was asking, the abdominal pain has increased in severity and now it has shifted and localized into the right iliac fossa. Now, can you narrow down your diagnosis from the general diagnosis?
Initially, pain was probably colic or intermittent. That intermittent nature was because of intestinal involvement or visceral pleura or peritoneum, and now it has localized to the right inferior quadrant. That means it has come down to the appendix or lower iliac region or some ascending colon region.
So now probably your diagnosis, can you, yes, Chetan?
Yeah, maybe we are dealing with acute appendicitis, but we don't know right now. We have to investigate this child.
Yeah,
but
definitely.
Suspicious is very high.
Yeah. Yeah, please, Chetan.
As such, a fever, vomiting, and abdominal pain, this still trial with maybe because of any viral infection or hepatitis.
Absolutely.
But here, which is typically what you have said is now pain has been transferred like from increase in severity and shifted to right iliac fossa. Now, this is very typical of appendicitis because many times what happens, patient comes in the morning hours with these non-specific symptoms. And even if we examine the patient, there won't be much of the tenderness anywhere because we know that this appendix and all this viscera, they don't have the somatic pain fibers. So they don't cause a pain. So whatever the pain is there, it is just inflammatory around surrounding
area.
Yeah. So that will be a dull aching pain. So you may not be able to diagnose it. So this happens in the morning hours, you see the patient, nothing is there. In the evening, patient comes with typical and just walking with that band.
How is the child is more important. He's sick looking, bending forward, not able to walk. He's in pain and agony, and parents are usually taking them in a lift and they come.
As soon as you ask them to lie down on the couch examination, they won't be able to lie down. So this is
we come to that posture. We will come to that postures and again.
We should be lucky enough to get him on the second day rather than on the first day.
Yeah.
If you many times what happens, we'll miss on the first day.
That has happened, sir. Very frequently it happens.
Yeah, it happened with me also. It happened with me also.
We tell them, if this continues, please come back. Please
that
come back.
Is what is initially the presentation of child was any non-specific. It could be because of any reason, but within few hours the pain is now localized, and we are now, our prime suspicion is appendicitis. Dr. Surendranath, what could be the common age group of the patients for appendicitis?
As per the consensus report, which is published in 2020, what it says is 10 to 30 years is the most commonest age group which presents with acute appendicitis. We do see the infants less than 10 also.
Yeah, we often see the less than 10 years, even up to 3 years, but it is rarely seen. It is not that common in. Yeah, Chetan, you wanted it?
Yeah, this is basically typical age group of the appendicitis because we know that ultimately the pathogenesis is what has been put forward is the obstruction of that particular appendix. So there is a submucosal lymphoid follicles, which are, at birth, we know that they are less. As the age progresses, in particular in teenager or, school age, there is an increased number of the lymphoid follicles. That's the reason wherever there is inflammation, there will be obstruction. So this comes in the that school age group children. Appendicitis.
One more point, sir. The girl child, she is a girl child. You have to think of other causes of ovarian pathology also.
Yeah, definitely. But it is just 10 years, so probably it is less likely. If it would have been still further, 15, 16 years, then definitely that would have been a priority. Yeah, next. Now, with your suspicion of the appendicitis, what do you want to look in the clinical examinations? You were just asking about the postures and other things. Can you enumerate now, one by one? Posture.
First and most important thing is as soon as the child comes, that's a posture.
Yeah, next slide, Atul.
The way he comes into the chamber. Secondly, when I ask him to go on the couch, they will be having just holding that abdomen very just to protect them. And once they are allowed to sleep on the couch, what will happen? They would try to sleep on the right side with the limbs are folded. And usually they will be, very much afraid of as soon as we try to examine them. So first is look, which is almost, patient is in agony or pain. That is continuous. And then you ask them to lie down, you examine. Then you would like to see what is the tummy issue, on examination, what is on for abdominal examination. So when you suspect a case of appendicitis, the first and foremost thing is we should not start examining from right iliac fossa. You should go to the other iliac fossa, start palpating from there gradually. Gradually, you just move the finger anti-clockwise and then you reach to the right iliac fossa, and gradually you increase the pressure. Otherwise,
that
it will
is
be
the
very
rule
much.
for any abdominal pain. From
Yes.
a less painful area, you should go to the painful area. Yeah,
Correct.
definitely.
So
Yes.
here it is right iliac fossa, so we'll start from left iliac fossa.
Definitely.
And then you
yes.
will try to see what is exactly, whether it is a tenderness, whether you get a guarding or rigidity, because the child will, because of having a pain, they would try to protect it by the muscle spasm. So it will be guarding and rigidity. And if you can feel that suddenly you press and relieve it, there will be rebound tenderness, and that will be clear cut, will be pointing out that it's appendicitis.
Yes,
Sir,
Dr. Surinder.
Sir, really sorry to interrupt, but you have last 10 minutes. We are running really short of time. So just 10 more minutes, please.
Yeah. Please, we will make it little fast. Surinder, what is the importance of McBurney's point?
Yeah, McBurney's point is the point where from the umbilicus to the right iliac spine at the.
So you will have a tenderness at the McBurney's point.
Specific tenderness at that point suggests that acute appendicitis. Most of the time, what happens is in acute appendicitis, obviously people say that immediately you see that if you suspect acute appendicitis, immediately see McBurney's point tenderness is there or not. Instead of seeing the entire abdomen, just see there is any tenderness up there or not.
Then it is confirmatory diagnosis.
You can put a finger.
Next.
You can put a finger on that, and if it is tender, it will be giving diagnosis. Right.
Yeah, Atul, next. So there are few other signs like Rovic signs, Suas signs, and obturator signs. All this in a form is for the relaxation of the local muscles over the right iliac fossa. So if you try to avoid that relaxation, the child will not allow, and that will be the painful procedure. So we can elicit various signs accordingly. We will not go in detail because of the lack of time. Next, Atul. This was a clinical diagnosis. Do we require any blood test, Dr. Kaur?
Yeah. Clinical diagnosis has to be confirmed with laboratory and other investigations like ultrasonography. Further, in laboratory, we'll do CBC. We'll see that whether it is acute inflammatory process, polymorphonuclear leukocytosis.
Yes, next, Atul.
CRP is raised. Okay, and we'll do, if that is there, then we'll do ultrasonography to confirm whether it is acute appendicitis or not. And there are
CRP will add to it. All septic screen markers should be done, including CBC and CRP.
Not all, but CBC and CRP is a basic, and with urine examination.
Yeah, and urine examination to rule out. Yeah, and to guide further and to improve the accuracy of the diagnosis, various scoring system has been advised. This is one of them, which is commonly used, like pediatric appendicitis score, where some of the clinical criteria as well as some of the laboratory criteria has been given various scoring. And if the score is less than 4 or equal to 4, it is less likely to be appendicitis. If it is more than 8, it is highly suggestive of appendicitis. And in between 4 to 8, it is inconclusive. Next slide. Any role of imaging studies, sir? Dr. Kore.
Definitely, because ultrasonography is easily available, non-invasive, and gives very much accurately the diagnosis of appendicitis nowadays, because the probe clarity has increased. Ultrasonography is really helpful in this case.
So these are the various findings that you get on ultrasonography.
More than 6 millimeter and wall thickness of more than 2 millimeter. They are almost, if clinically suggestive of appendicitis.
Definitely. Primary suspicion should be done. In addition to this, should be done.
Then
so
this
that
is
could be please.
Most importantly, when you do USG, you should be knowing that it will be 90% sensitive. So there are chances of 80 to 90%. So 20% there are chances that it may not pick up, because maybe if the patient is obese or if it is gaseous shadow, they may not be able to pick up, or it is a retrocecal.
So appendix is on the abnormal position, not in the routine position.
Now,
then you will not pick up.
Most important point is the probe tenderness of appendicitis. Then when they are putting a probe, they might feel that
the
it
child
is.
will mourn. Yeah, that is the biggest.
So that is very clear that it is that, and they won't be able to compress it, because usually they move the probe just to remove the ascending colon and come. Then they will try to figure out the appendix.
It will not be compressible.
Yes. So that is that's the way the even sonologists will tell us that with confidence that this is appendicitis.
Yeah. Any role of CT, Surendranath?
As per the algorithmic recommendations, ultrasound is the one should be done in all those cases of doubtful cases where scoring is more. So if the scoring is less, even ultrasound is also not recommended. You can wait and watch. So once the ultrasound is done, still ultrasound do not give any suggestion of the acute appendicitis. Still you are suspecting that clinically it is acute appendicitis. CT scan can be done. Low exposure CT scan with contrast is preferable than doing a regular CT scan.
So always do, if you are doing CT, always do with contrast. And these are the findings that you will get with the CT scan. Next slide, Atul.
CT is a gold standard for appendicitis diagnosis.
But you will not prefer CT as a primary because ultrasonograph is easily available and it is in situ in majority of the hospitals.
90 to 95% specificity and sensitivity.
Any role of plain X-ray chest, plain X-ray abdomen,
No, not much of a role. Definitely there is not much of a role.
Not for the primary diagnosis, but in case of complicated cases, definitely one can go for it. Next slide.
You might find sometimes gas under diaphragm and
when you find a complication of the abdominal perforation, yes.
Perforation, yeah.
What could be the antibiotic of choice, Dr. Mahesh?
Yeah, similar to the previous case.
So we do not discuss antibiotic.
Yeah, yes, we'll skip
we
it.
had already discussed it.
That's why I said similar to the previous case.
Yes, next slide, Atul.
Usually there will be difference between if it is appendicitis, which is not perforated, and if it is perforated. Just like bacterial peritonitis, and if it is not perforated, it is an intact appendicitis, where we may not go for very high antibiotics or may not be very...
Third generation cephalosporins are enough for this.
Yeah, next, Atul. And of course, supportive care. Next. Now the surgical intervention. What will be the criteria for going for the surgical intervention? Whether you would like to try with the antibiotics or you will immediately jump to the surgical intervention. Surendranath.
Depending on the scoring chart which you have shown, no? If it is less than 4 score is there, then you can wait and watch. Do a repeat scan after a few hours or one day.
The diagnosis of appendicitis is confirmed. This is a case
then in that case, what we have to do is ultrasound we have to do. If there is a appendicular lith, appendilith is there, definitely it has to be operated. Only
obstructed.
Yeah.
So obstruction has to be removed. So the child should be subjected to surgical intervention, whether it is open laparotomy or the laparoscopic surgery, depending upon the surgical skill and the availability of the surgeons in the local area. Yeah.
And one more thing is children should be operated before 12 hours because likelihood of rupture is more common in children compared to
more likely in the next. Yeah. So if it has to be done, it has to be done as early as possible. Yeah, Dr. Atul, next case.
Sir, sorry, just last 2 minutes, please.
Yeah.
We can stop here. Yeah, no problem.
Yeah, you can stop this case and summarize it, Dr. Atul.
I will. Can I go just a short case within 3 minutes, madam?
Yeah, fine. Please start it.
4 years female child had a fever since 8 days without focus. Received amoxicillin, amox club for 3 days and ceftriaxone for 4 days, and pain in abdomen and occasional vomiting. Child was febrile, toxic. It was like a fever without focus, no icterus. There was tachycardia. On systemic examination, there was tachycardia. Per abdominal examination, liver was 5 cm palpable, spleen not palpable. The hemoglobin 9.1 with leukocytosis, platelet 5 lakhs. SGPT was 78. Antiprobian was 2,500 because this was 6 months back case, so it was done. CRP was 395. ESR 120.
Are we thinking of MIC?
And, this investigation, what you are thinking? Okay.
Sir, one thing, sir.
Clinically,
one thing, sir. Any fever which is not responding to the antibiotics for more than 1 week, think of some pus somewhere. Or if it is a pneumonia not responding, think of empyema. Yeah. If you can't see any local focal signs with a fever more than 8 days which is not responding to the antibiotics, definitely you have to do an ultrasound, look for any localized collection of pus or localized infection somewhere.
Also in presence of CRP, very high CRP, that will definitely pinch that there is some pus somewhere. So sonography will be the answer.
So it is the infection where you are thinking of infection or another possibility of
inflammation. Non-infective inflammation can also be there nowadays.
So D-dimer was done, PT, APTT, serum ferritin was a higher side, but COVID antibody, RT-PCR antibody all were negative. So, and there were no eyes and skin involvement and cardiac involvement. Echo was also normal. So what Chetan wants to know about the blood culture was sent. So the ultrasound was done, abdomen. It was showing 4/3 hypoechoic lesion in the right lobe of liver, and in the 8 segmented hepatomegaly, mild ascites, basal pleural effusion on right side. So what is your diagnosis?
Now it is a liver abscess, and why there is a liver abscess, whether it is an immunocompromised child or an immunocompetent child. Then we have to answer these questions first. Why he has a liver abscess in the first place?
Okay. CT scan was done. Whether CT scan is indicated at this stage?
Single liver abscess may not require CT scan, but if they are multiple and not able to visualize the correct situation, then CT scan is needed.
Okay, because the ultrasonography is one of the good modalities. So you can rely upon the ultrasonography. If it is impending to rupture or in the odd space, or as you said, a multiple, you can go for CT scan, or you want to aspirate also, you can go with the ultrasound guide aspiration.
Sometimes.
So what are the sources of,
Sometimes what happens, day 5, 6 or 7 of fever, we are not getting anything. We are only having that CRP which is high and no other symptoms. Then we might go for sonography and you might miss it. So in that case also you might go for, with strong suspicion, CT scan you will get it.
Yeah, you can get that. So we are not going into this, what are the sources, but you may get from the biliary tract or from the portal vein or contagious infection. What are the risk factors? Dr. Kore was asking, what are the risk factors for getting the liver abscess? Dr. Mahesh.
Nowadays, any solid organ abscess has to be evaluated for primary immune deficiency.
Okay.
Yeah, any. If it is immunocompetent, HIV negative child also, you have to evaluate for PID.
Deep-seated abscesses, one should evaluate for PID. So CGD.
And most common would be CGD, chronic granulomatous disease.
Yeah. So what are the laboratory features? What is the diagnostic? You may get on an X-ray. You may get if it is on the superior lobe quadrant, you can elevated dome of diaphragm.
Now we have confirmed that it is liver abscess. Go ahead.
Yeah. So sonography is the good modality for confirmation, and sometimes you may go for the CT scan if required.
I'm really running very late. They're already half an hour late. Really sorry.
Okay, we'll
stop it. Okay.
The message from this is any solid liver abscess, solid organ abscess, we have to think of PID in an immunocompetent child, means not HIV negative child. We have to think of PID, chronic granulomatous disease.
Just we'll go for the last slide. If the liver abscess is 3 centimeter, single or multiple, start with antibiotic, which can be third generation cephalosporin plus metronidazole. And in this percutaneous drainage may not be required. If more than 3 centimeter unilocular, and give antibiotics, child not responding, do for needle aspiration, and or sometimes catheter. Catheter usually is required, percutaneous catheter more than 5 centimeter in size. And if it is multilocular, start with antibiotic, percutaneous drainage, and surgical therapy if abscess is not fever is not responding, or we are not able to drain the abscess. So this is broad management of liver abscess. The antibiotic to be used are as third generation cephalosporin or piperacillin tazobactam. And if you are suspecting MRSA, because Staphylococcus aureus is one of the commonest organism, you can add with the vancomycin also in few of the cases. I think we stop here. Thank you very much. Thank you all the
I thank my all panelists, co-panelists, Dr. Atul, panelists, Dr. Chetan Trivedi, Dr. Mahesh Kore, and Dr. Surendranath. Thanks for the wonderful discussion. Thank you, Dr. Sushruta, for allowing us to extend our time. Thank you.
Thank you so much.
Thank you so much, the moderators as well as the panelists, for a lovely talk. We are running really late, that's why I just had to really
Absolutely fine, no issue, please.
So now quickly we just a message for the delegates that because of lack of time, it's difficult to answer all questions. So please put them in the chat box, and the experts please to answer respective questions in the chat box. So quickly moving to the next session, which is a guest lecture on invasive fungal infections by Dr. Winsley Rose. And we have the chairpersons is Dr. Shekhar Biswas and Dr. Sandesh Runwal. So Dr. Shekhar Biswas is a consultant in the Department of Pediatrics and Neonatology at Jaipur Golden Hospital, and is awarded Honorary Fellow of CMS by the Alma Mater CMS Group of Institutions, Lucknow, India. He is a trainer for IAP, NRP and NNF programs, and he has multiple publications to his credit. Dr. Sandesh Runwal is a consultant pediatrician at Isha Kids Clinic, Pune, and Inamdar Multi-Speciality Hospital, Pune, and at present is the joint treasurer of the IAP Pune for 2021. And Dr. Winsley Rose, the speaker for the today's session on invasive fungal infections, is Professor at Department of Pediatrics at CMC Vellore, and his area of interest being tropical infections, tuberculosis, and vaccines. So I hand over to the moderators of the session. Yes.
Hello. Yeah. Since we have a present topic of invasive fungal infections, we have the updates for this presently. And in this recent months only, we have seen a lot of cases of fungal infection, although in adult population. But now everybody has been alert about the fungal infection and all those things, talking everybody everywhere. So to have the updates in pediatric age group as well, we'll have Dr. Rose to have his talk on this present session. Over to you, Dr. Rose.
I'll try and share my slides. Please tell me whether it's visible, and if I'm audible. Yes, visible. My slide visible?
Yeah, visible.
Yeah, and I'm audible. Okay.
Yeah.
Yeah, I really thank IAP Pune for this opportunity. I think past few years I've come there for these sessions, but unfortunately at this year I think we haven't been able to have anything in person. But in a way, it's probably good that you could actually get many more people to participate, both as faculty as well as participants to be in this session. My session, I'll try and sort of finish it in the next 15-20 minutes on invasive fungal infections. All of you, I think it's sort of, there is a lot of buzz in the air about black fungus and white fungus and yellow fungus. So what is this? What is invasive fungal infections? So my talk is going to be structured in this manner. So I'm going to talk a little bit about what are invasive fungal infections, how do we make a diagnosis of invasive fungal infections, some information on the update with regards to investigations, and then how do we treat them. So what do we mean when we say invasive fungal infections? So there is no strict definition as to what an invasive fungal infection is. So any systemic, generalized, deep-seated, visceral, and severe life-threatening fungal infection is termed as invasive fungal infection. This opposed to the usual superficial, local, benign, self-limiting fungal disease. So the common causes of invasive fungal infections are, it could be yeasts, which are the single-celled organisms, Candida and Cryptococcus, or it could be molds, of which Aspergillus and mucormycosis is probably the biggest ones. But there are other molds which cause invasive fungal disease as well, like hylohyphomycetes. The commonest one from them are Fusarium and Scedosporium. Then Phaeohyphomycetes, so Alternaria and Cladophyllophora. So these are unusual organisms. Of the molds, the most common are aspergillosis caused by many species of aspergillus, and mucormycosis, of which the commonest is probably rhizopus and then mucor. So there are many organisms within the order Mucorales which actually cause the mucormycosis. The other common causes of invasive fungal infection are pneumocystis infections, pneumocystis jirovecii infections. I mean, I won't talk about that so much today because of limited time. And the next is endemic fungal infections, of which the commonest ones are histoplasmosis. Probably we don't see blastomycosis, coccidioidomycosis, or paracoccidioidomycosis. We'll come to why we don't see it. And so the commonest endemic fungi that we see are probably penicillosis, sporotrichosis, and histoplasmosis. So we'll when the thing about these endemic fungi are, they are so limited to geographic distribution that if you don't live in a certain area, you will not have that infection. For example, if you don't live in South America, you can never have paracoccidioidomycosis. So they are very limited to their geographic location. So that's why they're called endemic fungal infections. So how does one make a diagnosis of invasive fungal infections? So there are three components that are important. First is a host factor. I mean, all invasive fungal infections require a host factor. There has to be something which is about the host that leads on to this invasive fungal infection. That also means to say it's very unlikely that somebody without an underlying problem, be it diabetes or some immunocompromised disease or something like that, having invasive fungal infections. Then next is clinical features. So when I say clinical features, when we think about any other syndromes, we probably, when we say clinical features, we think symptoms and examination features. Whereas for fungal infections, you should also include imaging features. So along the clinical features, we also include imaging features. Then we'll have to have a mycological evidence to say that it is a certain fungus, because it's very difficult. I mean, since these are all, most often these are immunocompromised children, it's very difficult to guess what the actual fungal infection would be. I'll come to why it is so important to get that mycological evidence. So I mentioned about the host factors. So we look at some of the host factors which are important for molds. So this is for mucormycosis. So some of the risk factors are diabetes, myeloproliferative disorders, acute AIDS, organ transplants, renal failure, polytrauma, burns, IV drug abuse, long-term steroid use, cytotoxic chemotherapy, broad-spectrum antibiotics, desferrioxamine therapy. I mean, see, these are some of the risk factors. Like if you look at some of these, like myeloproliferative disorders, AIDS, organ transplants, failure, renal failures, these are risk factors for other molds as well. When I say other molds, Aspergillus, also the other molds like, Scedosporum or Fusarium. So these are all the risk factors for them as well. So these are sort of common risk factors for molds. Now, I didn't put up COVID in that group, but we all know that there is something which has happened over the past year where there is such increase in mucormycosis, which is especially associated with COVID. So there are some postulates as to why this could be, and I've sort of listed some of these postulates. One is hypoxia itself. Then there is hyperglycemia. I mean, there are a lot of people who come with COVID and then you find out that, oh, they're now actually they're diabetics, or there could be new onset hyperglycemia, or it could be steroid-induced hyperglycemia, or then there is also an acidic medium because of the metabolic acidosis, which could be either because of DKA or even because of metabolic acidosis because of the sickness. High iron levels, increased ferritin. So that again can cause predisposed to mucormycosis. Then you can have decreased phagocytic activity with WBCs due to immunosuppression, either due to steroids or background comorbidities or the SARS-CoV-2 virus itself. And a lot of these people are actually hospitalized for a long time, either with or without mechanical ventilation. So all of these actually contribute to COVID, adults with COVID developing more mucormycosis. Now, whether children develop mucormycosis, children do develop mucormycosis. We have not seen any child in our own experience. I mean, we've had about 100 children with COVID. 1,000 children with COVID. And out of the 1,000, I mean, we've had about 80 of them going into ICU, but nobody developed mucormycosis. So if you look at published literature also, there is not much about mucormycosis in children. But there are newspaper reports which say that there are, especially in Maharashtra, that there have been children affected with mucormycosis. In our own experience, mucormycosis, our biggest risk factor is either cancer chemotherapy or diabetes mellitus. That's our biggest risk factor for mucormycosis. Now, what about invasive candidiasis? Now, I told you about molds. Now, with invasive candidiasis, the risk factors are slightly different. Just because somebody has spent a lot of time in ICU itself can be a risk factor. If they have a central venous catheter or have a weakened immune system because of any chemotherapeutic agent or steroids, that is a risk factor. Or if they've had multiple surgeries, especially abdominal surgeries, because Candida colonizes the gut, and if you breach that, that leads on to invasive candidiasis. Or if they have had many antibiotics, because of which there is selective growth of candidal organisms either in the gut and the mucosal surfaces. Receiving parenteral nutrition, children with chronic renal failure or hemodialysis, or if they have diabetes. And we know that in newborns, especially preterm babies, are at a higher risk for invasive candidiasis. So whenever you think about invasive fungal infection, think what is their underlying risk factor. If there is no risk factor, less likely that it will be an invasive candidal infection. Now, what about endemic mycosis? I told you most invasive fungal infections require an underlying risk factor. Whereas for endemic mycosis, even without a risk factor for a host, they can actually develop disease due to these organisms. But what is important here is it is endemic, which means you have to be present in that area. So if you look at this map of the world, it looks like actually India has only sporotrichosis. But actually India will have sporotrichosis, there is histoplasmosis, there is the odd penicilliosis, and rarely blastomycosis. But whereas coccidioidomycosis, paracoccidioidomycosis, those are all not there in India. So like in India, we should consider histoplasmosis, sporotrichosis, and penicilliosis. And these can happen even in non-neutropenic or children without underlying risk factors. So we looked at what are some of the host factors that predispose somebody to a invasive fungal infection. Next, we look at what are those clinical features. I mentioned clinical features don't necessarily mean only history and examination. It also means imaging features. So this is a recent publication in CID, which actually tells us what are those things that we should look for when we diagnose a mold infection. So if you want to think about pulmonary aspergillosis, then you look at these CT findings. Now, mind you, we have not looked at history or examination. What we go to because is actually the CT finding, because hardly you may not find anything on a clinical examination. So, and what are those patterns in CT that we're looking for? One, dense, well-circumscribed lesions with or without a halo sign. I'll come to what a halo sign is in the next slide. Air crescent sign, presence of a cavity, or wedge-shaped and segmental or lobar consolidation. And if you're considering other pulmonary mold diseases, like even mucormycosis, you should also look at the possibility of a reverse halo sign. Again, we look at what that is. If it's tracheobronchitis, you should have tracheobronchial ulceration or a nodule, pseudomembrane or a plaque or an eschar, which is often seen only in a bronchoscopic analysis. If you have sinonasal disease, you can have acute localized pain, including pain that radiates to the eye. There could be a nasal ulcer with a black eschar, extension from the paranasal sinuses across bony barriers, including the orbit. And if you want to diagnose CNS infections, they usually have focal lesions on imaging or meningeal enhancement to suggest meningitis. These are some of the clinical features of invasive mucormycosis. Now, this is an extensive surgery which exposes the muscle with the black mucormycosis infecting that exposed area. This is somebody with lid edema and ptosis. Again, this is rhinocerebral, this is orbital mucormycosis. Here is someone with lid edema and proptosis. Here is someone with the D is someone with a palatal blackish eschar, which again is rhinocerebral disease due to mucormycosis. This E is a child with it's a 3-year-old with leukemia who's come with this extensive lesion involving the both sinuses and the nose and the orbit. Again, this is mucormycosis. F again suggests mucormycosis. G is actually a eschar, black eschar, which is there on the neck. So all of these are actually features suggestive of mucormycosis. But you cannot treat based on this. You'll have to do a biopsy to actually make a definitive diagnosis. What about CT findings? So what is shown in A, the figure A is what actually shows the mucormycosis with the halo sign. That is, you have a radio opaque nodule with the some sort of a ground glass appearance, which is actually the halo sign. Now you look at figure B, within the halo, you find that it's actually more, it looks sort of radiolucent. So this is darker compared to the halo. Whereas in figure A, it is whiter compared to the halo. So this is called the reversed halo sign. Or the one in D is also a reversed halo sign. Or you can have hypodense lesions like seen in E. Or you can have a rapidly expansile lesion, which is seen in G, where the lesion is actually rapidly progressive within a few days. Or you can have lesions which traverses planes. Like usually when you have a bacterial pneumonia, if you have a pneumonia, it just sticks to the lungs. Whereas if you have like this is in figure F, if you have a invasive fungal infection, it can cut across planes. So here there is consolidation, which is because of pneumonia, but it is going through the diaphragm and infecting the spleen as well. So all these are suggestive of an invasive fungal infection. These are all features of mucormycosis. Again, similar features with invasive aspergillosis. Here again, you have a nodule. You have a nodule with a halo sign. And here you have a consolidation with a air crescent sign, which is trapped air within the consolidated lung. So all these are suggestive of invasive aspergillosis. To call it invasive candidiasis, you should have at least one of the following after an episode of candidemia within 2 weeks, where you can have small target-like abscesses either in the liver or in the spleen, which are all called bullseye lesions, or in the brain, or even meningeal enhancement. Or you can have progressive retinal exudates or vitreal opacities on ophthalmological examination. So remember, candidemia usually presents with hepatosplenic lesions or eye lesions. So that's the thing to remember. Now, what about mycological evidence? So that is key. Even though the CT may look like invasive aspergillosis, finally, for all you know, it may be mucormycosis. So it is it's very, very important as much as possible to find the mycological evidence. So how do we do mycological evidence? The best thing to do is to do a tissue biopsy and do a culture. Now, in the tissue biopsy, since these are all immunocompromised people, there are other things which can cause similar lesions as well. Like, for example, if you find gram-positive filamentous bacteria, it could be actinomyces. That means it could be nocardia or actinomyces. In this scenario, you have branching filamentous fungi, which are septate. Now, the moment you see septate fungal hyphae, you should think maybe this is aspergillus. And the moment you think aseptate fungal hyphae, you must think that this is zygomycosis or mucormycosis. Mucormycosis is also zygomycosis. So you should worry about zygomycosis. Now, mind you, zygomycosis, you can have subcutaneous zygomycosis as well. which is not necessarily in somebody who's immunocompromised, and it is actually subcutaneous. It's not deep organ disease. But aseptate fungal hyphae means zygomycosis. Then, if you have pseudo hyphae, that reflects Candida. So, the very important is doing a tissue biopsy and then culturing it. And all of these organisms can be cultured. Now, culture will give you a definite answer as to what the fungus is. Also, culture you might be able to get susceptibility testing if you have a culture which is positive. This is especially important in Candida. There are a couple of other tests which can be done, which actually indicate an invasive fungal infection. The first is galactomannan. Galactomannan, it's the polysaccharide component of cell wall of Aspergillus. Now, you can consider it as a significant value if the serum or plasma value is more than 1. These are all optical density values, more than 1. Ball fluid more than 1, or if you have a single serum or plasma more than 0.7 plus a ball fluid which is more than 0.8, or if you have a CSF which is more than 1. All of these are suggestive of an invasive Aspergillus infection. The thing to remember, this galactomannan is very specific only for invasive aspergillosis and not for other fungal infections. I'll come to some false positives later. What's the utility of this test? One, in somebody who has got invasive aspergillosis, you can serially monitor it to see whether they are improving or not. If it is coming down, it means they're improving. If it's not coming down, it's going up, maybe you're not treating it adequately. Also, if somebody who's got a high-risk malignancy with, a high-grade malignancy with a high risk for invasive aspergillosis, by doing serial galactomannan, if it suddenly becomes positive, you may even pick up aspergillosis even before they have any clinical features of aspergillosis. So in that way, it is useful. Some things to remember, it can cause false positives with IV piperacillin tazobactam and IV amoxiclav. Of the latest preparations of piptaz don't really give false positivity, but the earlier preparations used to. There can be some cross-reacting antigens with the fusarium, penicillium, and histoplasma. Also, if your gut integrity is diminished, that happens in the first 100 days of transplant, or if you have extensive GI mucositis or GVHD, there can be false positive with the galactomannan test. The next test which can be used is the beta-D-glucan assay. The beta-D-glucan is actually a cell wall component of many fungi. But importantly, it does not form a part of mucor, of the order Mucorales or Cryptococcosis. So that's the important thing about this beta-D-glucan assay. So any value which is less than 60 picograms per mil is considered negative, intermediate if it is 60 to 79, and positive if it is more than 80. You can have false positivity with where cellulose membranes are used, like in hemodialysis or in IV filters. It can give you a false positive with IVIG or albumin administration or IV amoxiclav. And certain bacteria, especially Pseudomonas aeruginosa, can give you a false positive beta-D-glucan assay. The utility is actually in finding out if somebody has got invasive fungal infection either with Aspergillus, Pneumocystis, or Candida species. Importantly, mucor and mucormycosis and cryptococcosis do not give a positive result. And it's useful for early detection of invasive fungal infections, especially by serial testing. So if you have a high-grade malignancy, you do serial testing with beta-D-glucan and it goes up, then you should worry about whether it is because of one of these infections, Aspergillus, Pneumocystis, or Candidal infection. Other useful tests are blood cultures. Now, blood cultures, you can get positives with yeasts like Candida and Cryptococcus, not molds. The only mold which gives you a positive blood culture is Fusarium. None of the other molds which give you a positive blood culture. Rarely histoplasma, which is an endemic fungus, can give you a false positive. There can be, if you are suspecting histoplasmosis, you can do histoplasma antigen in the urine. Suspecting cryptococcosis, again, you can do cryptococcal antigen in the urine or in the blood. You can do PCRs. I mean, PCRs, especially for pneumocystis and cryptococcus. Or if you do not know what fungus it is, or if you have a fungal organism and you want to identify the organism, you can do an 18S rRNA PCR to detect what fungus it is. Now, remember, since fungi are ubiquitous environmental organisms, there's a lot of potential for contamination. So this doing very highly sensitive tests like PCR, you should be worried about whether it is contamination and whether you're actually looking at the actual causative organism for that particular clinical scenario. Finally,
so sorry, last 5 minutes for you.
Yeah. So finally, we look at treatment. So there are only a few drugs which is used for invasive fungal infections. We have some azoles, of which fluconazole, voriconazole, isavuconazole, posaconazole, of which we use fluconazole, voriconazole, and posaconazole. Then you have polyenes, which is amphotericin B, 5-flucytosine, which is useful in meningeal disease due to Candida or Cryptococcus. Then you can have echinocandids. So we'll come to where these are useful. I'll just end with a case. So we had a 7-year-old girl who actually came with CNS leukemia. She presented with central diabetes insipidus, CSF confirmed leukemia. She was started on chemotherapy. She became neutropenic. On day 17, she developed fever. We started her on empiric ceftriaxone, sulbactam, and amikacin, which was subsequently changed to meropenem, teicoplanin, and colistin, and then changed over, and amphotericin was added. On day 27, she even worsened, and she had status epilepticus requiring ventilation. This was a CT scan, MRI, which actually showed this lesion in the occipital region. Some more lesions which came up, by day 30, she developed hemiparesis, and there were more lesions. But we didn't know what caused all this. Now, in an immunocompromised child, anything could cause this. It could be nocardia, it could be Candida, it could be mucor, it could be aspergillus. We didn't know what it was. So, but they refused a brain biopsy. Luckily for us, we had a galactomannan which was very high. So we thought, okay, maybe it is because of aspergillus. There was a sputum culture which grew many species of aspergillus. But luckily for us, she developed actually these skin lesions. So that biopsy of that skin lesion grew Aspergillus teres. Now she was on treatment with caspofungin and amphotericin and acyclovir. But clinically, she did not improve at all. And since this is suggestive of a disseminated infection and these skin nodules grew Aspergillus teres, we thought maybe the actual thing was Aspergillus teres. And mind you, Aspergillus teres is one aspergillus which has reduced susceptibility to amphotericin B. So we actually gave her salvage therapy with posaconazole, and then she improved. So the point I'm trying to make is it is important to find out what organism it is, because the antibiotic susceptibility actually varies with different organisms. So how do we treat invasive aspergillosis? First line is voriconazole, single agent. If you can't give that, amphotericin. Salvage therapy can be with an azole like posaconazole plus echinocandin. If on voriconazole, you can switch to another class like amphotericin. Just be aware, Aspergillus teres is resistant to amphotericin, and Aspergillus fumigatus can have high MICs to azoles. So the other important component of treatment is reduction of immune suppression. How do we treat mucormycosis? Surgical reduction plus antifungals. What antifungals would you use? The best thing is actually to give amphotericin. I have not specified whether it's amphotericin B or liposomal. Liposomal is definitely better. If you need to give salvage therapy, it's either posaconazole or isavuconazole. We've used it to a fair extent. Combination therapy are anecdotal and really not recommended by guidelines, and people have tried as amphotericin plus azole or amphotericin plus echinocandin. Mind you, echinocandins, mucor, which is rhizopus, can be susceptible to echinocandin. Invasive candidiasis, if they are neutropenic, first line is echinocandin, then amphotericin, and fluconazole if there is no azole, if azole resistance is unlikely and the patient is not sick. If it's a non-neutropenic patient, you can give echinocandin or fluconazole. and if azole resistance is unlikely and the patient is not sick, and amphotericin if it's resistant to other agents. Remember, candidal meningitis treatment includes flucytosine. It really improves the rate of cure. Finally, I mean, if you want to take a picture, it's probably a good thing of this, because antifungal susceptibility actually is dependent on the species of the fungus. So if you know what species it is, you can actually predict the antifungal susceptibility. You don't need a antifungal susceptibility testing result to actually determine what antifungal you want to give. So just 2 points to make. Zygomycetes are resistant to azoles other than posaconazole. So zygomycetes, if you want to treat with an azole, it has to be posaconazole. Otherwise, it is amphotericin. Whereas azoles, a lot of azoles are actually susceptible to, I mean, for aspergillus, a lot of aspergillus are susceptible to azoles as well as amphotericin other than aspergillus teres. Remember, caspofungin works only against candida and aspergillus. It does not work against mucormycosis. With that, I'll stop. Thank you.
Thank you, Dr. Winsley. I think it was very exhaustive talk on this need of the hour, because nowadays we are seeing mucormycosis. Luckily, couldn't see in our place of practice also. Luckily, kids were there in ICU, but they improved without any fungal infection. Thank you. And the questions are welcome. If anybody has any questions, they can put on the chat box.
Thank you, panelists, for a wonderful talk. Since we are short of time, quickly moving ahead to the next session.
Thank you.
Okay, thank you, everybody.
Thank you. Thank you.
Thank you.
So, moving ahead to the next session. Just give me a minute. Yeah. Moving ahead to the next session, we have a rapid fire 10-minute 3 sessions. I would please request the speakers to restrain themselves for 10 minutes, and then just 2 minutes before I will give you an intimation of the talk. Only 2 minutes. Rapid fire session. First session being oral cavity in pediatrics by Dr. Sanjay Mankar. Second would be otitis media points to mind by Dr. Mycobacteria, Dr. Ashwani Sood. The chairpersons for this session are Dr. Vijay G and Dr. G. Please mute yourself. Professor of Pediatrics, MGM Hospital, Medical College, Warangal, Telangana, 2017, a member of ACVIP and he has 24 publications to his credit. Dr. Gopal Bandhu Nanda is a senior consultant at Pediatrics College.
Ma'am, your screen is not visible.
My screen is not visible?
No, ma'am.
It's okay, Shushruta, you can continue.
Sharing mode.
Okay. The CIAP
It's okay, Shushruta, you continue.
Please share again.
2019 and okay, should I share again?
Yes, ma'am.
Yeah, just a minute.
Shushruta, I think it will just waste time, you continue.
Okay, so moving ahead, we go ahead to the first session on oral cavity in pediatric infections by Dr. Sanjay Mankar. I'll just stop sharing. Yes, Dr. Mankar, please.
Hello. Yeah, thank you, Sushruta. Can you hear me all? So, hello, can you?
Yes, I can hear you.
My slides are visible?
Yes, yes.
Yeah. So, good afternoon to all of you. And at the outset, I would like to thank the organizer, IAP Infectious Disease Chapter and IAP Pune for the invite. In the current pandemic of COVID-19, we try to avoid examination of throat, but examination of throat is extremely useful in the diagnosis of various infectious diseases, which may include bacterial, viral, fungal, parasitic, and other. Coming to the bacterial infections, which affect the oral cavity, the diphtheria commonly presents with a low-grade fever, anorexia, and throat pain. And there is a classical formation of the membrane, which is a pseudomembrane, whitish in color, adherent to the lower mucosa, and when it's tried to remove, it bleeds. The membrane can spread to the other part of the oral cavity, and they will bleed on touch. The extent of the membrane will decide how much antitoxin has to be given. It may range from 40,000 to 1 lakh unit. The the complications of diphtheria like palatal palsy, which is shown over here, can be monitored by examination of oral cavity, which may present with just regurgitation, as well as sometimes the streptococcal pharyngitis may be confused with the diphthetic membrane, but the streptococcal pharyngitis, the membrane is a non-adherent membrane. Other part of the pharynx may not be involved. It is restricted to the tonsils and it will not bleed on touch. The lymphoid hyperplasia of the posterior pharyngeal wall may be seen in the case of streptococcal pharyngitis. When it is classical strawberry tongue, along with the inflammation of the pharynx, redness of the oral mucosa, and appearance of the classical sandpaper-like rash appearing on the first or the second day of the fever is highly suggestive of a scarlet fever. Scarlet fever is a clinical diagnosis because the streptococcal rapid antigen test may not be available everywhere and culture may take a longer time. Similar kind of picture, which is a milder form, may be seen with the Archaeobacterium hemolyticus like picture. These lesions are rare nowadays, but these are the moist white plaque lesions which are present on the tongue. They are highly suggestive of congenital syphilis known as condyloma lata. The condyloma lata, they are moist lesions which are elevated, highly infectious, contain more amount of a treponema pallidum. Other oral cavity lesions which are there are radiating lesions from the angle of mouth, which later on shows bleeding and scarring and may give sunrise like appearance, which are known as raggeds, is another feature of late congenital syphilis. Upper incisor, which is a notched screwdriver shaped incisor, which is known as a Hutchinson teeth, is again a late feature of congenital syphilis. Though the syphilis is rare nowadays, it do exist. Acute epiglottitis, rare in India at present, caused by Haemophilus influenzae, may present with a fever, sore throat, and difficulty in swallowing. Stridor is a late feature of acute epiglottitis. More than 700 microbial species do colonize in oral cavity. Neither all of them are culturable nor they are pathogenic, but they can cause various diseases when the child is having different kind of immunity. Dental caries commonly occurs because of the Streptococcus mutans. They are followed by infection due to lactobacillus and actinomyces. Dental caries can lead to formation of apical root abscess, and they also may lead to formation of periodontal disease. All of these may spread to the palatal and can cause palatal abscess formation. They also lead to sometimes osteomyelitis, and the child may come to you with a high-grade fever, pain, and facial swelling. These abscesses and dental manipulation whenever is required, if the child has a previous attack of an endocarditis, or if the child has a previous congenital heart disease or a valvular heart disease, may require endocarditis prophylaxis while removal of the tooth with the amoxicillin 50 milligram per kg of half an hour prior to surgery. Acute ulcerative necrotizing gingivitis is a hallmark of Vincent's angina, which is classically seen with the Fusobacterium and spirochete infection, and should be treated with the amoxiclav and sometimes may need metronidazole therapy. This is a classical Ludwig's angina. The child has presented with the swelling in the submandibular area and sublingual area with the edema of the tongue, and the tongue has been shifted to the roof along with airway compromise may be the feature, and the commonest pathogen here is either Fusobacterium or Peptostreptococcus, and needs very prompt treatment either with the surgery and with the antibiotics. Ludwig's angina and other infection, parapharyngeal infection, can lead to lamellus disease in a pediatric age group. This is the rare form of disease known as actinomyces, which has got rare but chronic discharging sinuses, which presents after the abscess, and this discharging sinuses may show sulfur containing granule, which is the hallmark of actinomyces, and the treatment consists of giving penicillin for 6 months. Alternative drugs are erythromycin or clindamycin. Retropharyngeal abscess, parapharyngeal abscess, and peritonsillar abscess may present with a fever, drooling of saliva, difficulty in swallowing. With the retropharyngeal abscess, examination of oral cavity may reveal unilateral swelling or midline swelling. Parapharyngeal abscesses may show medial displacement of the lateral wall along with the lower tonsillar pole, which is shifted. Coming to the fungal infections, which was very well covered by Dr. Winsley Rowe just now. Oral thrush is very common in neonates, but it is rare after the age of 1 year. Recurrent and persistent fungal infection of the oral cavity, immunocompromised condition has to be ruled out. You can see a white, curdy white membrane, pseudomembrane, which is there on the oral cavity, which may involve almost all part of the oral pharynx, and when removed, it will have an inflamed area and a pinpoint tiny hemorrhages inside, most commonly caused by Candida albicans, but it can be also Candida tropicalis and Candida krusei. They respond well to the local application of clotrimazole. Sometimes only erythema or angular chelosis may be the presenting feature of oral candidiasis. This child is a 6-year-old child presented with who is an immunocompromised child suffering from leukemia on cancer chemotherapy, had prolonged fever, facial swelling and erythema, and presented with a plaque-like elevated lesion on hard palate, which was initially erythematous and later on turning to be a violaceous and now almost turning to the black. So whenever such immunocompromised patients come to you, always think of molds, as was given by Dr. Winsley Rose very clearly. So this child was subjected to surgery, debridement was done, and after debridement, tissue culture was done. This tissue culture showed classical aspergillosis, and it was confirmed by histopathological examination that there are septate hyphae with acute angle branching, which is highly suggestive of aspergillosis. Sometimes aspergillosis is very difficult to differentiate from mucormycosis, but the aspergillosis mainly involves sinuses. When there is an involvement of orbit, it is highly suggestive of a mucormycosis. Mucormycosis more commonly affect diabetic individual, but it can also affect immunocompromised individual. It is very important to differentiate them by histopathological examination because the treatment of both the condition is different. The drug of choice for aspergillosis remains voriconazole, but if you give voriconazole for mucormycosis, mucor may be aggravated. The drug of choice for mucormycosis will remain either amphotericin V with posaconazole or isavuconazole. So that is a mucormycosis.
Sir, last 2 minutes, please.
Sorry, I will finish. Okay. So this is a very common scenario in nowadays practice. The child coming to with a high-grade fever of more than 3 days duration, red eyes, which is a non-exudative, then mucocutaneous changes in form of the red lips, red tongue, also with the rash on the body, and raised CRP, highly suggestive of multisystemic inflammatory syndrome, which is associated with COVID-19. The mucocutaneous changes of the COVID-19 are almost indistinguishable from those of the Kawasaki disease. When other viruses are also important cause of tonsillopharyngitis, when the child has got a fever of a prolonged duration along with the exudative tonsillitis like this and conjunctivitis, which is with hemorrhages, it is highly suggestive of pharyngoconjunctival fever, which is caused by adenovirus infection. The child coming with the fever and lymphadenopathy, especially epitrochlear lymph nodes are enlarged, and the child has got an exudative pharyngitis along with the palatal petechiae, and a rash after giving an amoxicillin is highly suggestive of infectious mononucleosis. The child with the herpes simplex infection commonly present as a vesicular lesions at the angle of mouth. These lesions spread gradually on the lip. They ulcerate later on and forms scabs. They also spreads on the gingival surface and cause herpetic gingivostomatitis. It also involves the anterior part of the pharynx. It doesn't involve the posterior, but the anterior part of the pharynx is commonly involved and should be promptly treated with IV acyclovir or oral acyclovir, and the child may require hospitalization because of not eating anything. The posterior lesions on this thing are highly suggestive of herpangina, which is caused by enterovirus infection. As we have said, herpes simplex infection commonly involves anterior part. Herpangina commonly involves posterior part of the body. When painful lesions, ulcerative lesions on anterior part of the tongue, along with the vesicular rash on the hand, buttocks, and foot, are highly suggestive of hand-foot-mouth disease caused by again Coxsackie and enteroviruses. The classical ulcerative lesions, which are involving uvula and fold, is highly suggestive of human herpes 6 virus infection known as Nagayama spots. While when the child has a fever of 3-4 days duration along with the cochlear spots, you can diagnose measles prior to the appearance of the rash. While when the rash appears and at the same time there is a palatal rose pink lesions or a petechial lesions, they are highly suggestive of rubella Forshamer spots. The child with ulcerative lesions and vesicular rash on the body is highly suggestive of chickenpox, varicella. While the child who is having recurrent abscess ulceration, the child less than 3 years old having shallow ulcers with the surrounding erythema, they heal without any scarring, and the child has a recurrent fever which is recurring periodically along with raised inflammatory marker, and stomatitis, pharyngitis, and adenitis is suggestive of periodic fever. Though a non-infectious condition, it responds well to the steroids. When the oral cavity is open, it provides clues to the various infectious diseases, but whenever there is a difficulty in opening oral cavity, it is suggestive of trismus. Trismus also suggests tetanus, retropharyngeal, parapharyngeal abscesses, and dental infections. Thank you very much.
Thank you, sir, for a very quick and a very pictorial presentation. Could we quickly move on to the next speaker in the session?
Hello, hello, madam.
Yes, sir.
I'm Dr. Nanda. Next session is Otitis media wants to mind. It is Dr. Yaswant Rao. Dr. Rao, you are muted. You are muted. Dr. Rao, you are muted. Unmute.
Yeah, good evening, everybody. I thank IAP Pune for giving me an opportunity. My topic is Otitis media points to mind. Yeah. Otitis media is a spectrum of disease. We have otitis media, non-suppurative otitis media, then ASOM, and ME, which is most common in infant between 6 to 3 years. And we have predisposing factors or risk factors for AOM, which is common between 6 months to 36 months. It's common in children who are using pacifiers, attending daycare centers, who are being bottle fed or drink while lying down. It is more common, or they are predisposed when parents is one of them is a smoker, and whenever there is a sudden change of season. So what is ME?
ME is middle ear effusion. Characteristic features are you will have a limited mobility of tympanic membrane, abnormal tympanic membrane color. You will find opacification of tympanic membrane not due to scarring. You will have air fluid levels behind the tympanic membrane, and apart from that, you will have otitis media with effusion without any inflammation. The major difference between OME and is very important. It should be noticed that because in times of antibiotic discrimination, if there is no inflammation, there is a thin layer between AOM and AOM, OME and AOM, where we can avoid antibiotics as much as possible. And AOM is middle ear effusion with acute ear pain marked by redness of tympanic membrane, and you have a distinct bulging of the tympanic membrane. Every child who has suspected acute otitis media should be evaluated by otoscopy, and it is mandatory that on 10th day of treatment, you should do a otoscopy. So what are the guidelines for treating acute otitis media? Moderate to severe bulging of tympanic membrane or new onset of otorrhea, not due to any otitis externa, should be considered as otitis media. Mild bulging of tympanic membrane and recent onset of ear pain less than 48 hours should be considered. And AOM should be diagnosed in children without middle ear effusion. So when to start antibiotic therapy in children with acute otitis media? It should be started in children who are less than 6 months of age. Even if you have a suspected case of antibiotic, the AOM, since there is increased chance of complications. Acute otitis media with otorrhea, any age, irrespective of 6 months to 36, it can be considered. Bilateral or unilateral AOM in children less than 6 months or older with severe symptoms where you will have severe pain, then you will have fever more than 102 degrees. Bilateral AOM in children less than 24 months without any of the signs and symptoms, or if there is unilateral AOM with severe symptoms. So normally when we have a suspicion of acute otitis media and when we have diagnosed after using otoscopy, the major stage is the treatment by amoxicillin, where we have to use 40 mg per kg in uncomplicated one. If a patient has already used acute otitis media 1 month prior to this, amoxiclav can be considered, where 40 mg per kg per day along with clavinet at 6.4 mg per day should be considered. And for those who have received amoxicillin or who have concurrent purulent conjunctivitis or recurrent otitis media not responding to amoxicillin, such patients can be treated with ceftriaxone with 50 mg per kg per day, either IV, continuously for 3 days. So what are the second line drugs which are used in otitis media, where they are not responding to 48 to 72 hours of therapy of suspected otitis media? We have Cefnir, where 14 mg per kg per day is given in divided dose, where 30 mg per kg per day is given in divided doses. Cefpodoxime is given. Media, second line drug where clindamycin can be given along with third generation cephalosporin. You have to give clindamycin at the dose of 30 mg per kg per day, with or without cephalosporin. So what is recurrent otitis media? When we have 3 episodes in 6 months or 4 episodes in a year with 1 episode in the preceding 6 months, we can suspect as recurrent otitis media, where we have to choose the second line drugs which I have mentioned in the previous one. Who are the people who are prone to otitis media or who are called at otitis prone? They are children who have 4 or more episodes in a year and at least in the 8 months period with middle ear effusion in a year. They are called as otitis prone children. Most of the time and 70% over by a period of 12 weeks. If we have the secondary treatment being still not efficient or still they continue over 12 weeks and children have chronic bilateral otitis media with associated hearing difficulties, it's a time where tympanostomy tube is the thought or the good. Recurrent otitis media with medullary effusion also is an indication for tympanostomy tube insertion. Tympanic tube insertion is optional when you have a risk for speech, language, or learning problems in recurrent otitis media. Irritability and otalgia. On performing otoscopy, you find red drum. Observe them. Red drum only is there without any signs. Just observe them. Red and bulging tympanic membrane disease. Start co-hemorrhagic clave as seen, and then if there is red bulging without any severe disease, we can treat as mild to moderate. In less than 2 years, we have to give amoxicillin for 7 to 10 days, and in more than 2 years, you have to wait and watch for 48 hours. Suppose on otoscopy there is wax, you have to remove wax by using the wax drops. It will resolve in you can come do a tympanometry, and empirical treatment can be started with ENT consultation. So as otalgia is severe and toxicity is high and fever is more than 1 or 2, media in children who are prone in between 6 to the Haemophilus influenza or the pneumococcus have come down, and you have to give them annual flu, which is recommended as per schedule. Encourage most of the time children with exclusive breastfeed for continuous 6 months. Avoid tobacco smoking, which is a parental part. So features. Thank you.
Thank you. Thank you, Dr. Yaswant Rao. You have explained very well about the otitis media and their how to treat it. Just a question, whether you will consider for the higher dose of amoxicillin?
Yes, sir. We are normally using 40 mg per kg in as well.
Hello.
You can give, sir.
Yeah. Okay. Thank you. Then I may call the next speaker, who is Dr. Ashwini Sood. Ashwini K. Sood. He will talk. His topic is non-tuberculous mycobacteria. Ashwini bhai.
Thank you, Dr. Nanda. But I am not able to share the screen. Ask Dr. Yashwanta to stop sharing his screen. And good afternoon to everyone. Thanks to IPA ID chapter and IAP Pune for giving me this opportunity to talk over very brief time, 10 minutes on NTM. So
you can share.
Yeah, you're right. Oh, you're looking very smart today.
Thank you.
So next 10 minutes, I'll try to do the justification. And we all know that this non-tuberculous mycobacterium, which we are going to refer as NTM, are an important emerging opportunistic pathogen of human. And the biggest issue is that it is not a notifiable disease. So we don't know what is the exact epidemiology, whether in India or other parts of the world. And remember that the two chronic frequent manifestation of chronic disease is chronic either adenitis in children, and whereas in adults it is responsible for pulmonary infections. But as per the emerging data, we will find out the reason. It is being reported that its incidence is increasing. And another factor is that most of the time the awareness among the clinician is low, And so what happens that patient which may be suspected with NTM may not be diagnosed and recognized. And again, it's a very notorious one because it's a very highly complex and treatment may have to last for 1.5 to 2 years. So these are different milestones. Just to put this cartoon here that over this time frame, how these bacteria were identified. What are these NTM? Basically, simply to remember when they are not assigned either to Mycobacterium tuberculosis or Mycobacterium leprae, and there are others named like environmental mycobacteria, so on, and how they are recognized. Soon after, people thought that Mycobacterium tuberculosis were not initially as a pathogenic, and their characteristics are very classical. So they are ubiquitous in environment. So there are a few inherent differences in NTM versus Mycobacterium. These are non-obligate pathogens and are normally living free in the environment. Importance is to know about their low virulence. And so far the evidence there is that there is minimal human-to-human transmission. And in developed countries are seeing more and more cases, probably better diagnostic. And these are large heterogeneous group of species. And when we further want to classify, they can be rapid, which grow between 7 to 10 days, and slow are between 1 to 3 weeks. At times may take around 8 weeks. So where they are found, so we can look, they are found in natural water resources, in drinking water distribution systems, hot tubs and spas, acidic, potting soils, and boreal forest soils and peats, and metal removal fluid system. So intimately, in a nutshell, we can say that their habitats are intimately shared with those of human. How are they transmitted? Either somebody is going to take as aerosols or dust, or there is ingestion of contaminated soil or water. Person-to-person transmission extremely rare, but in those patients with cystic fibrosis, maybe one of the possibility. And in hospital setting where water supply and medical equipment are contaminated. Recently, it is being said that even gastroesophageal reflux can lead to because of swelling of these NTM. So let's try to look into some evidence into what is NTM status in children as on today. But so far, unfortunately, there is not much data from India, even from the world. It is only case reports of 1 or 2 cases, and which people are trying to look. These are, we all know, they are having the potential to colonize and eventually infect either immunocompromised as well as the immunocompetent individuals. And the increased prevalence is explained by one is there is, especially in adults when there is aging population and with comorbidities. So is it an emerging threat? This is an Spanish article in 2019, interesting one. They looked into hospital analysis. They tried to look into in their region and looking for the age and gender of the patients. And what the authors concluded that over the time period of around 2005 to 12, you can take in 9 years, the incidence increased by 35%, where there were 21% decline in the MTV. So these were more common in males. And as for children, this is a rare disease, and the incidence is around 1 to 1.8 cases, and probably this is underreported. In adults, we know the lung is the most affected organ, and in pediatric age group, we can find out this cervicofacial lymphadenitis is very important, and there are few identified risk factors like contact with hens and the lack of BCG vaccination where it is stopped in those countries, and probably that may be the one of the reason that we are seeing less number of cases. So just to continue with the case series, try to look into in this country to children into case series of only 2 patients. One was 2-year-old girl, which was vaccinated with BCG. Other was 22-month-old in whom a misleading presentation led to delayed diagnosis. So generally, in both the cases, there was fistula formation, and diagnosis was made on the systemic cultures. So culture is again difficult. So author opined that this, as per their a literature review, which were a retrospective one. It is going to affect more of girls under 4 years and more frequently in winter and spring. And diagnosis can be made by clinical picture, positive Montus, but again, there is a rider, especially in our country, and resistance to conventional antibiotic, which are used for treatment of Appendicitis. So, as per these authors, the atypical mycobacteria and immunocompetent is being increasingly observed. And then we have this one last study from South India and one from AIMS. They looked into around 7,600 plus TB suspect samples. And as per these authors, this was probably for all age group. Thus, NTM was observed among around only 0.7% of pulmonary TB and around 4.4% of extrapulmonary TB from large series. And within pulmonary specimen, these were the different species which they were able to culture. And from extrapulmonary, they were able to culture Mycobacterium intercellulare or Sclerophacium and Percium, which were common in extrapulmonary specimens. So remember here, there is going to be a difference in the species in whether it is pulmonary and non-extrapulmonary. And as per the author's observation, the frequency is low in suspects, at least in southern part of our country. What are the common clinical and laboratory findings when we suspect? So remember that this just simulate TB infection, and rarely it can be associated with constitution symptoms, that is low-grade fever, generalized malaise, weight loss, or night sweats. So remember, in these children, laboratory findings may be normal or just maybe mild elevation of inflammatory markers. So just to summarize, so clinical feature are unilateral lymph node in the jaw angle, which are mobile. There's skin over the nodes is hyperemic. Invariably, there's fistula formation, and when we try to look into, then it is soft on consistency. So what are the laboratory tests to culture? Confirm the diagnosis. So it is recommended that we do the culture both in liquid as well as solid media. And if facilities are aware, then in a good sensitivity test is PCR. So it can be used to detect NTM, and results are available within 2 days. And microscopy is just in 1/3 of the cases. So remember, when we are doing talking about those conventional screening tests, they are less useful. And we all know that, especially in developing country where tuberculosis incidence is high, it will show a cross reaction between TB and VCG immunization. And it is said that one can use IGRA, which will be a better here. I don't know, there are not head-to-head studies which I could get in the literature. And it is said that some species like Mycobacterium marinum, Kansai, Suzuki, flavescens can cause false positive result also. So there are certain proven risk factors. For systemic are these we all know: immunodeficiencies, hematological malignancies, including graft versus host disease, HIV, and long-term use of steroids or other biological drugs, and some few mutations. And few studies interestingly come that vitamin D deficiency or receptor polypharmacy K could be one of the risk factor. What are local? Like skin barrier disruption, because more people are opting for cosmetic surgery and catheters. Sometimes there are corneal integrity alteration, that is LASIK surgery, and lung disease, we know cystic fibrosis, bronchiectasis, COPD, asthma, and air pollution. These are all risk factors. So it is said we don't have definite evidence what is the definitive therapy, but it's said that surgery could be gold standard. And this is one more advantage, that it provides a histological and microbiological diagnosis also, but there are chances of injury to the facial nerve. So it is recommended that early detection and intervention is important. So this is one reference which shows these are the recommended medications starting from clarithromycin or azithromycin, including rifampicin and ethambutol, and duration has to be 12 to 18 months. So this is the latest 2019 guidelines by IDSA and British Thoracic Society. And you can see this is a busy slide. So it gives all detail of all these drugs which can be used and which can be used in bacterial sensitive as well as long time.
The last 2 minutes, please.
Yeah, I'll finish it. So remember, there are both clinical as well as lab criteria. So clinically, I said that probably these are more towards the adults with the lung disease, and one has to make impression to look for microbiological evidence, and like as we are doing these days NTP, one should try to look into. This is a flow diagram for chronic iditis where it is more than 3 weeks and atypical, that is unilateral, fluctuant, and the skin is erythematous. So one need to look into PCR and culture along with FNA. And when we are looking into, especially in developing countries, one need to keep a very close watch on tubercular lymphadenitis, and then look into clinical as well as biopsy, and these are the different differentials starting from CME up to extracervical adenopathy. So important is criteria for NTM is then either one look into surgery, and another group says let's wait and see, and another is just to continue with erythromycin or other macrolides for 6 months. So how to do follow-up, that's important in these patients. So there has to be very regular and frequent monitoring and try to look for if there are any other side effects, hearing testing, and when the patients are put on long-term, then eye and ENT examination. So it is suggested that surgical resection for limited pulmonary disease may be curative because we can have both microbiological and tissue diagnosis. When these patients are on long-term medication, then it is suggested that we do the CBC and CMP monitoring every 3 to 4 months. And people in adults are using amikacin as inhalation. And then microbiological monitoring also recommended, so but CT scan, including CT scan. Just to summarize, treatment is multifactorial. It's not so easy to make a diagnosis. Non-pharmacological therapy, especially in adults, could be airway clearance, cessation of tobacco smoking, try to reduce exposure to those areas, exercise and nutrition, one need to take care, multi-drug therapy, and that's why because this therapy has to continue for a long time, so one need to monitor these patients medically for side effects, clinical symptoms or deterioration, try to look for evidence of microbiological and culture conversion, and radiological improvement. So this cartoon can show us that one is very close follow-up, exercise, and weight gain. So just to summarize, these are related to Mycobacterium tuberculosis NTM and are not obligate pathogens. So they are surviving in the environment, including all these water distribution system, and they are classified rapid and slow, as we discussed earlier. And outer membrane basically supports the dissemination adherence, so that they are able to form a biofilm which is responsible for their spread. Different clinical relevance for different species, maybe slow and rapid growing. And pulmonary disease, the most common form in both nodular and bronchiectatic. And the risk factors include geographic location, genetic factors, and underlying lung conditions. So because it is being now more and more recognized due to increased awareness, and the different data available from different countries are variable. It's a progressive lung disease and affect the patient quality of life. So it is important that it's important to have optimal guidelines for their optimal management in the presence of chronic underlying disease are needed at the time rightly now. Thank you very much for organized to giving me the time.
Thank you, Dr. Sood. And you have presented very well in short time. And definitely.
Yes. Thank you, sir, for a wonderful presentation. Now we move to the much awaited last topic of this session, a hot debate between two hot debaters on a hot topic, to be or not to be, to use or not to use steroids in pediatric practice. I'm sure
during the hot months.
Absolutely, both of you all, yes. I'm sure it's going to be extremely humorous and very educational also. I'll just share your series. Actually, you don't need it, but just a minute. And the judge is going to be Dr. G.V. Basavraj. Yes, so
I think the previous speaker needs to stop sharing.
No, it's fine, it's fine. They've already stopped sharing.
Yes, Dr. Basavraj is a professor of pediatrics and in charge of PICU, Indira Gandhi Institute of Child Health in Bangalore. He's a chairperson
this is not visible yet.
care. Sorry, it's not visible.
Yes, please share again.
Just give me a minute. Yes. Can you see this?
Not yet, ma'am. Yes, now,
Yes, now we can see.
Basavraj sir is going to be the judge. He's a professor of pediatrics and in charge of PICU, Indira Gandhi Institute of Child Health in Bangalore, and he's a course coordinator in pediatric intensive care. He's Honorary Secretary General Central IAP 2020-21, and he's the most dynamic person in today's era of COVID, where they've started a lot of digital courses. Dr. Upendra Kinzavdekar doesn't require any introduction. A great debater, a great orator, practicing pediatrician of Neral, has multiple publications, textbooks, and journals to his credit. Special interest in infectious disease and nutrition, and honorary treasurer of IAP in 2018 and 19. And last but not the least, our very own Dr. Pramod Zog, a senior pediatrician in Aun, with a rich experience of more than 35 years and a great sense of wit and humor. He's been the past president of IAP in 2016 and senior consultant to UNICEF and also the chief editor Times of Pediatrics. Just a minute. Stop sharing. Just 1 minute. I'll just stop sharing.
In the meanwhile, I'll just tell the rules of the debate. So both the speakers will get 7 minutes each, starting with Dr. Upendra first, followed by Dr. Pramod Zog sir, and then there will be a rebuttal time of 2 minutes each, followed by the verdict to be given by Basavraj sir, or he is expected to sum up the whole debate and then give his verdict, sir.
Thank you, Dr. Sanjay Nath. So steroid is one of the odd topic in the present era when the COVID started occurring almost from December 2019, but the reality of a steroid which came to the existence in 2020 April when the MISI was started. That's the time where the whole thing has been. We started using a steroid, and that is in fact it is something we need to be. Apart from the COVID-19, the steroid where we are using, where should not be used. This debate is going to give a clear-cut message at the end of the thing. I am sure rather than the debate, it is more of an educative, and the stalwarts in the field of pediatrics and pediatric infectious disease, none other than our Dr. Upendra Kinzavdekar and Dr. Pramod Zog, our past president. First, I invite Dr. Upendra Kinzavdekar to talk in favor of it. Over to you, Dr.
Good evening, friends. Dr. Nathu, these rules were not told to us that it would be just 7 minutes. So pardon us if 1 or 2 minutes extra are taken because I prepared for almost 10 minutes. Nevertheless, I am really surprised, and actually let me start with thanking Dr. Sanjay Nathu, the president of IAP Pune, also the ID chapter, and of course, all the colleagues in the ID chapter, those who have drafted this program for inviting us to be in the debate. In fact, we have not met physically, but this is the third time in the COVID pandemic, myself and Dr. Pramod Zog are debating on something or the else. So friends, when I talk about steroids, I'm reminded of my professor of pharmacology, who always said, you know, batches after batches, year after years, told us about story of Samudra Manthan, wherein actually the gods had lost their mortality, and because of the curse from sage Durvasa, and along with the help of Asuras, they started churning the sea in order to retrieve the nectar of immortality, which was nothing but Amrut. And sir always said Friends, we do not have Amrut right now, but in pharmacology, if there is one drug which is parallel to Amrut, it is nothing but corticosteroids. And look at the utility from JRA to asthma, from ulcerative colitis to autoimmune hemolytic anemia, from demyelinating disorders to nephrotic syndrome, from chronic urticaria to adrenocortical crisis, everywhere. And yes, even in infections too. So I'm really surprised why are we having a debate on the utility of steroids in pediatric infections. And what more glittering example you want me to give apart from SARS-CoV-2? It starts off with ACE2 receptor attachment, cytopathy effects, inflammation, and the child or the adult goes into hypoxemia. And which other drug which has proved the test of time apart from oxygen? It is corticosteroids, my dear friends. And then patient worsens, goes on to mechanical stress, inflamed mechanical stress epithelium, cytokines. But again, the drug which comes to your rescue is nothing but corticosteroids. So there, in severe and critical patients, we must use it because children were underrepresented in the clinical trials which supported the benefit of mechanical ventilation or those who required supplemental oxygen. WHO says give low dose glucocorticoids. The duration always, of course, remains 10 days or until discharge, whichever is shorter. And let me not go into the details of dosing, but what is important in all these patients of moderate to severe disease of SARS-CoV-2, it is corticosteroids, which is an evidence-based drug used. Let me go beyond that and start off with the bread and butter, the croup, which is nothing but the inspiratory stridor, the cough, irritating child comes to it with mild symptoms. But we always tell them go, but come back if your symptoms worsen, come back if it is moderate to severe. And which drug are we banking upon? It is steroids, my dear friends, because they not only decrease the intensity of viral croup, the symptomatology is not improved, but the need of epinephrine, the length of stay, the unscheduled visits, everything is drastically reduced. And how much? A single dose will give you a dramatic result in 30 minutes. So if the child is not vomiting, I'm going to ask him to take a prednisolone, or if it is vomiting, then injectable dexamethasone, or even a budesonide inhaled is also found to be useful. So yes, this becomes another infection, and it is nothing but a para-influenza causing the croup. Bronchiolitis, I can see many eyebrows raised over there. So I'm going to make a statement that clinicians should not administer corticosteroids to infants in the first episode of bronchiolitis in any settings. However, if this infant comes to you time and again, if it is getting recurrent hospitalization, if he has eczema and a first degree family member with asthma, a trial of steroids is worth and definitely shortens the duration of hospitalization. Let's move on to another common infection, enteric fever. The gold standard for diagnosis remains a blood culture, but we know that patients sometimes come in a complicated stage. A child with typhoid in delirium, in obtundation, in stupor, coma, shock. I do have to bank upon dexamethasone, 3 milligram per kg, followed by 1 milligram per kg for maximum of 48 hours. These adjunct corticosteroids did not increase the rate of any other complication, carriage, relapse. So you need not worry. Mind you, but these are only with the study of SIFT triaxone it has been done. So if the patient should be on proper antibiotic coverage, then only corticosteroids in such situations only are highly recommended. Let's move on to the disease which we have probably forgotten, though it is low in incidence, but if it comes, all of us know that in an acute phase of carditis or exudative pericarditis, I have to bank upon steroids. The duration will vary depending on the symptomatology and echocardiographic or the ECG changes of this patient. Do you know that it is chorea, which is also troublesome to a child? We know most of the times chorea spontaneously subsides, but if this child has preventing independent ambulation, if it is hampering his self-feeding, causing high calorie expenditure and weight loss, it is steroids which come to our rescue. And look at the duration of reduction of symptomatology from 9 weeks to 4 weeks. Isn't it amazing the utility of steroids? And how can I forget bacterial meningitis? Though I was extremely enthusiastic in using it to reduce complications early in the course, but definitely I know right now that it is preventing hearing loss in my hip meningitis. Of course, I'm going to have a relook of pneumococcal meningitis utility, but mind you, if the child comes really very in a delayed presentation, steroids will not work. And second important condition is penicillin-resistant pneumococcal meningitis. So if your child is on vancomycin, steroids will reduce the penetration of vancomycin into CSF. So be careful in that situation. And of course, even in meningococcal meningitis, I do not say. So these are the utilities of steroids here. And of course, tuberculous meningitis. I know about not only the mortality, but the morbidity it is causing, the disabling residual neurological deficits. I'm really worried about that. So HIV negative patient with a TBM, how can I complete the treatment without steroids? Of course, I won't say the same about HIV positive. Starting initially, I would have given 4 milligram per kg of prednisolone per week, followed by 2 milligram per kg for 3 weeks. But then it was associated though with few tuberculosis, but higher incidence of hearing loss. So right now, the recommendation is to prevent the increased risk of optic atrophy and hydrocephalus, give a dose of 2 milligram per kg per day, which will reduce the risk of mental retardation, spasticity. So steroids do help us even in the management of tuberculous meningitis. And finally, I can see my dear friend, the judge of today's debate is the intensivist. And he would say, Dr. Upendra, how are you missing septic shock? I know the effects of steroid, regulation of glucose metabolism, the protein breakdown, the increased lipolysis, the anti-inflammatory properties, stimulation to release polymorphonuclear lymphocytes. Everywhere steroids come to our help. Of course, they enhance the myocardial contractility. Of course, they increase the vascular smooth muscle tone. Of course, they decrease the capillary permeability. But am I going to recommend in every pediatric septic shock? No. There are two wonderful evidences which show that shorter shock reversal time for those who receive it early compared to those who received it later. That is one. And the decrease in median dopamine dose and median dose of norepinephrine. So even if the patient receives inotropic support, the dose is reduced. So these are the two evidences. But finally, I would say as a conclusive statement, the role of steroids in septic shock as of now today in 2021 is patients who are at risk for absolute adrenal insufficiency due to purpurofulminans or recent or chronic treatment with steroids, a hypothalamic pituitary abnormality, other causes of congenital or acquired adrenal insufficiency. They have to be treated with stress dose hydrocortisone early in the course of resuscitation. And secondly, those healthy patients who persist with shock in spite of rapid fluid administration and vasoactive infusion, I know they remain the cornerstone of treatment of any shock, should receive hydrocortisone. How much? In a stress dose, about 2 to 4 milligram per kg per day, intermittent or continuous, to a maximum dose of 200 milligram per day. And mind you, this is a wonderful terminology which has come in, a critical illness related corticosteroid insufficiency. So we must be aware of it and we must use it whenever judiciously, whenever required. However, because of definitive evidence of benefit in children is lacking, ongoing management, even without corticosteroid therapy, is a reasonable alternative, and I do accept it. So friends, I would like to conclude by saying the newer effective immunosuppressive and anti-inflammatory drugs are going to come. The targeted drugs such as biologic agents are going to come, and we are going to find some replacement for steroids, especially for long term, because they remain cornerstone for several pediatric diseases, including infections for acute treatment. But I understand the limitations for long-term treatment due to the onset of long list of adverse effects. So I must end by making a humble plea that we clinicians should carefully weigh the potential benefits against the risk before prescribing systemic corticosteroids in any infections. Thank you. Thank you very much.
Thank you, Dr. Upendra ji, for an excellent deliberation. Now we are eagerly waiting to listen to our past president, Professor Pramod Jog, and
Yes,
against the team. Over to Pramod Jog, sir.
Yes,
Pramod
yes.
Jog, sir, does not require any introduction. Though all the people are waiting to listen to both Upendra ji as well as Dr. Pramod.
Yes, yes.
Over to you, Pramod.
Thank you, Dr. Basavaraj. Thank you, Upendra. See, what Upendra mentioned about the uses of steroids, there is no doubt about the indications that he has given. But IAP is a combination of three alphabets: irrational, average pediatricians, and the perfectionists. Okay, so Upendra is from the last group of perfectionists. And there are pediatricians in our country who are affected by a novel HIV virus. What is this novel HIV virus? Those who have HIV, the habit of prescribing steroids, the ignorance about prescribing steroids, and various other factors related to prescription of steroids. And they are, some of them, they are from a group of what is called as Hanuman Pediatric Association. Why Hanuman Pediatric Association? Because, Hanuman brought the entire Dronagiri for treating unconscious Lakshmana. And these are the people who do not know as to when to use steroids. Okay, the ideal conditions everybody knows. Not that nobody knows the indications which Upendra said, but the problem is, see, that we know that the income tax is to be filed on a particular date.
we are supposed to follow the traffic signal, but we do not follow that. That is the main problem. Okay. And remember one important point. So let us see about this habit. I will tell you, once Khushwant Singh was asked as to when does he drink, and he said, I drink only on 2 occasions, one when it is raining and one when it is not raining. So there are many who are using steroids like these. Okay. So I will give an example. For example, child having cough following a viral infection. We all know that this is going to go on for 2 or 3 weeks. But then some IT sector parent comes. IT is not the information technology, but he is the inquisitive and the troublesome parent who comes and requests the pediatrician, sir, the cough is lingering on for a very long time. Now the pediatrician doesn't have the courage to say that this is post-viral cough. It will, subside within 2 to 3 weeks. So he prescribes steroids, n number of prescriptions. So there are people who are irrational pediatricians. And remember that some of them are other ones. They don't bother to document the infection also. They're very casual. They know that steroids are used in typhoid fever in some particular cases or in septic shock, but they are so much casual that they forget, the basic name of corticosteroids is corticosteroids. But these people forget the cortical part and start only prescribing and tocophying steroids. Okay, they are very casual. Okay, then there are other ones who are called as no sterophobics, just as they are having a phobia that if I do not prescribe steroids, okay, something wrong will happen. So they are impulsive pediatricians. And there is a third lot which is not only casual but also callous. Why callous? Because those pediatricians who are prescribing steroids in the first 7 days of COVID-19, where we know that the viral replication increases too much if we give it in the first week, they just give it for the defervescence of fever. So that is the problem. And I will tell you, the origin is in a word which is called as erotomania. You know what is erotomania? That means a boy, suppose let us take an example of a college going boy and a girl. He feels that the girl loves him, but actually she doesn't love him. Okay, but he continues to feel that she loves me, she loves me. Similarly, the pediatrician feels that steroids will work, but the steroids don't know that the pediatrician has that feeling in his mind. So ultimately what happens is that he gets a nice slap one fine day from the girl, and that is erotomania, for which people are prescribing steroids. Another important point is there are some preconceived ideas. The child will improve faster. If I do not use steroids, the child may worsen. Okay, in case of dengue, I use steroids, the platelet count will rise faster. In case of hepatitis A, if I use steroids, the child will have relief of itching, which is there because of the obstructive element. And then, as I said, in COVID-19, there will be faster defervescence of fever. And the height of it is particularly in a case of PUO, when there is no antibiotic working and there is no working diagnosis, the fellow simply irrationally gives steroids, and the child unfortunately turned out to be a leukemic child. Okay, so these are the areas, the preconceived ideas, and they unfortunately meet some people who are the academic gurus who are equally ignorant. And just as the in the Kaun Banega Karodpati, Amitabh calls and tells you to phone a friend, so he phones a friend who is equally ignorant, and he doesn't know which steroid is to be used where are you going to use methylprednisolone, when are you going to use dexamethasone. They don't know the relative potency, nothing. So they are the ignorant pediatricians, which I told you earlier. And then in COVID-19, enteric fever, I am glad that Upendra brought out the point about the earlier recommendation of giving 3 mg per kg initially high dose, and then 1 mg per kg 6 hourly for 48 hours. But I feel that these are the older recommendations. And I know when we were residents, we used to use steroids, particularly for myocarditis and then for encephalopathy and for shock. But I think these steroids at this moment, they give a false sense of security. There is a chance that the child may go in relapse. And, there could be a chance that the child, in case if he has a perforation, that may be masked. He also spoke about the septic shock. And I wonder as to how many are aware of the protocol, and a lot of knowledge is there, but wisdom is not there. Knowing that tomato is a fruit is okay, that's knowledge, but not to use in fruit salad. Tomato is not to be used in a fruit salad. That is wisdom. So many pediatricians do not have that wisdom, and that is the problem. And dengue, I just mentioned there. Recently, I asked one adult physician as to why they use steroids in dengue so rampantly. He said, Pramod, I want to prevent HLH. And in pediatric practice, we always we always feel that steroids should not be used. And as I said, there are many who use it just to increase the platelet count. And most of these indications which are there, particularly being followed by the irrational pediatricians, that is something which worries me. And another lot is there. Who knows that steroids are not to be used. Some places they have to use, they start using, and at a particular point they start using, but they do not have any monitoring. For example, a child who is on steroids may not have the classical signs and symptoms. As I said, it may mask certain signs, okay? And then there are problems. So if a child is celebrating happy birthday on steroids, that HBD of happy birthday will get converted into hypertension, increase in the blood sugar, and the deranged growth of the bones. Remember, so that happy birthday will be damaged by all these steroids. Then there are high risk problems related to steroids. For example, children will get more prone for COVID-19 because they are the ones which are immunosuppressed. As we heard earlier, one of the speakers who mentioned about the herpes simplex and the varicella zoster virus, which is so common in children who are on the steroid therapy, okay? And there is a risk of fulminant hepatitis in children with herpes simplex infection and CMV pneumonia in children who are immunocompromised. So there are many problems which are related to steroids. The problem is not that we don't know these side effects, we know that, but nobody monitors, and that is the problem. Dr. Kukreja mentioned about chickenpox in immunocompromised patients. So these are the children where monitoring is really required. So I would say that, we have to stop at some level. I will tell you the word stop. S means septic shock, where to use. T is typhoid, where to use. O is obviously viral infections, including dengue. And P stands for the other pervasive infections. So remember that particularly in these children, pediatricians are the ones who have to steer the steroids. They are the ones who should use their gray matter for taking the decisions in the gray areas where steroids are to be used. And that HPA axis suppression that we so often speak when we discuss about steroids, I will tell you HPA means from head to the pen, from head to the pen, the academic axis. HPA is the head to pen academic axis, which has to be really, really perfect, because we are living in an area where survival of the immunocompetent, survival of the immunologically fit people only will be the final answer in case of COVID. And that is why please individualize the treatment. And remember, in any child where steroids are being used, please look at the underlying condition, look at the suppression of HPA axis, and also look at the this reversal and adrenal insufficiency following withdrawal of the steroids. So all these factors have to be considered, and then only steroids are to be used. So that's all what I wanted to say. Thank you.
Thank you very much, Dr. Pramod Jog, sir, for an excellent summarization and also the rationality. Now we request Dr. Upendra ji to add if there is anything rebuttal.
No, I think this was not a debate, like as Dr. Pramod Jog very rightly said. So though, and it was a difference, the talk was, it was knowledge and wisdom from sir. So what I shared was knowledge of utilization of steroid, but the wisdom, I think that was very important. That all pediatricians, though aware of the indications, what is important to know the HPA axis, as he said, from head to pen via academic axis. So that is why if we are rational in using steroids in proper indications, I think that should be very important, because otherwise you and I definitely know the utilization of steroids in definite certain infections, but the indiscriminate use, injudicious use, prolonged use, without monitoring use, all we have to be really cautious about it. And as sir said, that talking about SARS-CoV-2, we know that one of the important factors which has resulted into the epidemic of mucormycosis in India, which was not seen in any of the Western countries, was probably early indiscriminate right from day one use of steroids. And they were given 2 to 4 milligram per kg, and probably these, apart from other factors, I think that was very, very important. So let us all be extremely, though as I said, I started off that Samudra Manthan story, and actually the sir used to say that it is the Amrut. It is definitely Amrut, because you can see the number of conditions that you can use steroids in, but then one has to be really judicious, rational, and use it appropriately to save rather than to kill or harm the patient. I think that is what I would like to say.
Yeah, thank you, Dr. Upendra ji. Dr. Pramod Jog, sir. I totally agree. Yes, sir. You want to add something?
No, only 1 minute only, nothing more than that. I feel now that the stage has come that we all have to act as role models for the general practitioners, because many pediatricians are now really, they have EIQ because of these E programs. We have enhanced IQ. That is what I feel. And we all must act really as a role model, and we must have a balanced view. And everyone, as I said, knows what is right and what is wrong. Some people say that I used steroids because it was a situational compulsion. The situation was such that I had to use. But he himself is the real person who knows what was that situational compulsion. And some people are not only irrational, but they are erratically irrational. They really don't know what they're doing, and they continue to do that. And I will request you to read one of my articles which I recently wrote on psychology of the irrationalist. Okay, I will forward it if possible. And that's why I appeal all of you to follow what is called as a steroid stewardship. Okay, we have been discussing about antibiotic stewardship. So let us also, take up steroid stewardship and some steroid strategy for the use of steroids. So maybe Dr. Basavaraj, in your tenure, you can take it up in future, and we can have a separate module. Okay. Thank you very much.
So you will be the national scientific convener.
Okay. Thank you.
Thank you. So thank you very much. Both views are absolutely rational. We need to know COVID-19. Yes, it requires a steroid. We also need to know timing of the steroid. We need to avoid during viremic phase. 2, we need to know the severity of the disease. It is required in a severe disease or moderate disease with hypoxia, timing and severity. And we need to know the duration. 5 to 7 days is most of the time it is good enough. It may be required a bit longer period depending upon the case. That is one. Multisystem inflammatory syndrome, that is the place where we are misusing the steroid, especially febrile inflammatory status and all. But we should know this is a diagnosis of exclusion where we are missing a lot of other than MIS-C, like leukemia, enteric fever, leptospira, scrub. One carry-home message there: before using the steroid, exclude the other possibility. That is related to the COVID-19. Dr. Upendra and Pramod Jog sir both are in the same page. It is my job is becoming very easier there. Croup. We should know croup. Croup is a condition where single dose of steroid is a magic with a 0.6 milligram per kg. But we should not use irrationally, especially in a moderate and severe. Answer is yes. Mild, if the health access is not possible, yes, you can. But using it for longer period, it is not acceptable. That is where the thing really lies: single dose steroid and inhalation, budesonide and all. That's with the croup. Coming to the bronchiolitis, the carry-home message is very clear. Bronchiolitis, which is caused by RSV virus, which is likely to behave like a reactive airway disease to some of the people, some of the children. That is where Dr. Upendra ji has brought it very clearly, and even Pramod Jog sir also agreed with that. Whenever there is a reactive airway disease like our transient wheeze, whatever the terminology we use, Sanjay Nathu was also a part of our mini respite during Pramod Jog sir time. We have brought it very clearly. That is where your steroid, not in all bronchiolitis, which is behaving like a reactive airway disease because of an RSV virus infection, which is well documented in textbook of Nelson, that's where you can. Then comes to enteric fever. I totally agree with what Pramod Jog sir said. When we were a postgraduate, enteric toxemia is one of the clinical condition where you used to left and right, 3 milligram followed by 1 milligram, which was there in Nelson. It is a relatively old recommendation. I'll agree with that. But the epidemiological presentation of enteric toxemia, nowadays, once in a while we get, that is toxemic encephalopathy or enteric toxemia presented with a shock. That situation, your steroid is a life-saving, not in all enteric fever. That's the balancing act we need to do as a clinician. Then comes rheumatic fever. Of course, we hardly see a case of rheumatic fever. It's a thing which works a magic thing. I'll not go into that. Coming to the bacterial meningitis, before starting antibiotic, if you start a steroid, especially in H influenza, answer is yes. Rest of the things is 1-to-1. Tubercular meningitis, of course, Upendra ji has brought it very clearly. Septic shock, yes. Catecholamine resistant shock, adrenal insufficiency, that's the time where you can. Misuse, dengue fever, Pramod sir has clearly brought it out. To here, don't chase your platelet count, chase your hemodynamics. That's the message. So steroid has no role in dengue, except dengue is causing HLH. That's the time where you can use an steroid, otherwise no role for a thing. Hepatitis A, answer is no. PEO, answer is no. So both the speakers are fantastic. Really, I enjoyed both of your debate. In fact, I learned a lot of things with your debate. Nothing to judge, just I summarized it, what you all said. Thank you very much. Thank you for excellent debate. It is not rather than a debate, it is a more of both are highly educated. Thank you so much, Pramod Jog sir and Upendra ji, for your excellent deliberation. Over to Sanjay Nathu or Sushruta Deshmukh madam.
जसं म्हणतो तसं आजच्या प्रोग्रामची सांगता या ह्याच्यापेक्षा उत्तम प्रोग्राम निघू शकणार नाही. So it was a wonderful debate and thank you so much all of you, all the delegates, the panelists and everybody who attended this in huge numbers. I saw that it was more than 200 of attendance every day. We promise to come back tomorrow with another academic feast. Till then, it's goodbye from our side. I hand it over to Sanjay.
Yeah, so thank you, Basavaraj sir, Pramod Jog sir, and Upendra sir for this wonderful end to today's session. And as Sushruta said, we'll be back for the date 2 tomorrow morning sharp at 9 a.m. Thank you all.
Thank you, Pramod.
Thank you, sir.
Yes.
Sushruta madam, thank you. Pramod Jog sir, thank you.
Yes.
Thank you, Basavaraj sir. Sanjay, thanks.
Thank you, sir. Thank you, Basavaraj sir. Thank you, Pramod sir. Yes, sir.
Thank you.
Bye.
Yashwantrao, bye.
Bye, Upendra sir. Sanjay Nathu, thank you.
Yes, thank you, sir. Thank you, Rao sir.
Neely Bas.
Sir, Basavaraj sir.
Yes, sir.
Thank you. I'll talk to you later.
Vasdev, good evening.
Namaskar.
Thank you. Bye, Sanjay. Bye,
Thank you, sir. Thank you, Dr. Neely.
Well done.
Thank you, sir.
Hearty congrats for the grand success.